Within a 10 second, we will live to audience, sir.
Yes. Give us a countdown, please.
Yes, yes. So, sir, is 3, 2, 1. Over to you, sir. We are live to audience the platform.
Thank you. Good morning. Again, this is the second Sunday of the month of March of 2026, and we are again here with another edition of FOGSI ICOG PG Clinic. It is a program run for last 4 to 5 years, and we are thankful and we are obliged to President FOGSI, Dr. Bhaskar sir, FOGSI ICOG Chairperson, Dr. Sheila Mane, and today we have Dr. Pratik Tambe, Secretary ICOG, for their continuous support and guidance for continuation of this program. We are thankful to our ICOG GC member also today who have joined. And at the beginning, I would also like to welcome our faculty member. Today we have Dr. Hemant Deshpande. He is Deputy Dean and Professor and Head from D.Y. Patil Medical College, Pune. He will be demonstrating the shoulder standoff, a demonstration of life-saving technique in shoulder dystocia. Then we have case discussion from GMERS Medical College, Ahmedabad. And we are thankful to Dr. Mayur Gandhi as a coordinating faculty to coordinate a case discussion from our student, Dr. Mehta and Dr. Vartika Kumari. And we have our esteemed faculty to discuss the case, Dr. Ashish Mukhopadhyay, Dr. Shailja Bidri from Vijaypura, Karnataka, Dr. Uma Pandey from BHU Varanasi, Dr. Rujuta from GMCH Nagpur, and Dr. Kodkar Doke, Associate Professor from Arunachal Pradesh. And thankful and we welcome you, sir, from so far area. And after that, we will be having specimen demonstration, which is another important component in the exam. And Dr. Arup Maji will be discussing this specimens for with the students. And in the end, we have a quiz from FOGSI Quiz Committee Chairperson, Dr. Archana Kumari. So with this program today, I hope our student will be benefited. And before we proceed further, I request our Chairperson, Dr. Sheila Mane, to say a few words.
So, good morning and thank you, Dr. Ashok Kumar, for taking up this initiative. And as it is going on since 5 years, and I think, as we always say, that Indian College of Obstetrics and Gynecology is for academics, and we really want the postgraduate programs to happen in a very standardized way, so that, you know, all over the country, we can train them, they can get an exposure of examiners as well as the professors from the different medical colleges from all zones. And I think that is possible only through ICOG, as we can go nationwide. So as you said, I think today again we have amalgamation of the professors from west, from north, from east, as well as from south. And the students, Shivangini and Vartika, best of luck and we welcome you. And it's an opportunity for you to present a case on the national platform. And thank you, Dr. Ashish Mukherjee, for being there as an expert for this program. And Dr. Hafizur, again, who works hard in the background to bring everybody together. So I welcome you all, and we would also like to see that those postgraduates who have joined, quickly, if you can share this link with all your colleagues and see to it that more and more people join, as well as the teachers, those who have joined, let them join. I think Dr. Mayur Gandhi to see to it that from Gujarat you get people, as well as Rujuta from Nagpur, yes, and Vidarbha and Maharashtra, from our Dr. Shailaja from South, and I think we have Dr. Gotar Dok from Northeast. So try to see that more and more people join and get benefit of this. So once again, happy International Women's Day. We give to gain, okay? And the theme is we give to gain. And today, through this program, we are going to give a knowledge and which should gain a women's health in our country. So That is how I think this PG program stands today, Give to Gain on an International Women's Day. And thank you once again. And I think you can proceed. Dr. Pratik, if you want to say something, our secretary.
Thank you, ma'am. So I think a lot has already been enumerated by our eminent chairperson, Dr. Sheila Mane. My congratulations to the conveners of this long-standing program, Professor Ashok Kumar, Dr. Ashish Kumar Mukhopadhyay, and Dr. Hafizur Rahman, one of the unsung heroes of our ICOG. Thank you very much for all your hard work and coordination. I also place on record my gratitude to our academic partners, Aristo, who have given us the platform and who helped to coordinate this program. In fact, just yesterday I was talking to them that a lot of hard work, coordination, effort goes into organizing this program, conceiving of it, bringing together diverse faculty from different parts of the country to benefit our postgraduate students. But not enough students are logged in, and we need to do more to try and make this
Exactly.
popular and disseminate this all over the country. So we're going to have a brainstorming meeting maybe in a couple of weeks, and we will try and see to it that this reaches out to more and more deserving students from all over the country. Thank you very much for the opportunity to speak. I hand over back to the organizer.
And I also welcome Dr. Arup Maji. Again, one of our governing council member, I think, who will be taking a class on specimens. Welcome, Dr. Arup Maji. And all my GC members who have joined, thank you for joining.
So thank you, Dr. Sheila Madam, and thank you, Dr. Pratik Tambe, for giving us a pearl of wisdom. It is our endeavor that we involve medical college from different areas of the country, far from the main metros and big cities, and we try to involve faculties also from far remote areas so that at least ICOG reaches to these areas and these PG programs are there for them to help and guide their students also. So it is both for teachers as well as for the students. And we as a team, I along with Dr. Ashish Mukhopadhyay and Hafizur Rahman, we all try to see that our target and our objectives are met. And this time we have faculty from Arunachal Pradesh, and we see that we have involved and we are evolving with the time as the NMC guidelines changes. We have involved a skill development program in our program, and then today we are discussing specimens also for the student. So purpose is to have a all-round preparation for the examination, along with the some points emphasized by NMC. We see to it that we stick to those programs which are needed as per the NMC also. So with all these outlined, I now request Dr. Ashish Mukhopadhyay to say a few words, and then we hand over the proceedings.
Submission, Dr. Ashok.
Yes, madam.
One submission, you also announce about the ODC program, so that, yeah, late, or if you want to do it now or in between, you just see, we can just, Ramnath, I mean, the rest of people can share that flyer also in between, so that, as well as the journal club, which we have.
Yes,
okay?
So we are having another program for the teachers for teaching learning methods. What are the different teaching learning methods and how to be well prepared for teaching learning methods? Because NMC again emphasizing on the competency based learning for the students, for the UG as well as for the PGs. So last year Dr. Parag Binewala thought of starting this ODC program as a teaching learning method for the teachers. So this we will be having now program next in the coming week on Wednesday from 2 p.m. onwards. And I request you can spread the message, and we'll be sharing the flyer with all of you so that we can, as a teacher, become very strong and we understand the need of our students nowadays and what all we are supposed to teach them and what are the different new methods which are coming up in teaching learning methods. And these are the again requirement of NMC also. So with these words, I now hand over to Ashish sir for further proceedings, and then Hafiz will start the program.
Thank you, Dr. Ashok Kumar, and I think I need to be short because time is going away. And I thank everyone. A happy good morning to all of you, and a happy International Women's Day to all. And yes, 5 years is a long time, and we have been running this program for long 5 years. That just shows its acceptability to the students. And not only that, we are evolving continuously. We are just changing according to changing NMC guidelines. That's a big thing about it. I think the students should be aware of this, as well as the teachers should be, aware of this, that what are the changes that are happening at the background at the NMC level. One of the reasons why the spectators, or rather the login number is less, maybe that everything of this is available at the ICOG website, and everybody can go back to the website and go through this program. So it adds to the convenience, but that doesn't mean that we won't try to involve the all the parts of the country. And it has been our conscious effort to involve many far-reaching areas, and also the diverse faculties, heterogeneous faculties. Today's Arunachal Pradesh is a good example, and I think we are going in the right direction with some standardization and some protocol we maintain about this structured programming. And to add spice to this, we have added quiz just a few months ago. I think the program is running fine, and we wish to continue in the same manner with constant suggestions on involvement, on improvement, on betterment for the benefit of the students. Thank you very much, and Hafiz will lead the program.
Good morning, everyone. Thank you so much, Ashish sir and Ashok sir. My sincere regards to FOGSI President Dr. Bhaskar Pal sir and ICOG Chairperson Dr. Sheila Mane Madam, ICOG Secretary Dr. Pratik Tambe, and all the office bearers of FOGSI, ICOG, and as well as all the faculties, those who have there today with us, all the governing council members of ICOG, and the students, those who are representing. So we'll go by session, as I think Sheila Mane Madam, Ashok sir and Ashish sir has already given, that is, this program is going for 5 years. So we'll go session by session, and without wasting much time, I would like to have start the first session, that is which is very important. And actually I got a request from many students to have this topic, and Hemant Deshpande sir is very expert on this, and sir very muchly agreed for this topic. That is the shoulder standoff expert demonstration of life-saving skills. So I am very much sure that this will be immensely benefit to the students, and they will have, along with their academic as well as improvement of the technical skill. So Dr. Hemant Deshpande sir is Deputy Dean and Professor and Head of OBGYN at Dr. D.Y. Patil Medical College, Pune, Maharashtra. So I'd like to request Dr. Hemant Deshpande sir. Over to you, sir. Hemant sir. This session is yours.
Thank you.
Thank you so much for accepting the invitation.
Thank you. Very good morning, Team ICOG, Team FOGSI, for this opportunity. I'll try to be in time for delivering this particular talk. Hafiz, my slides are seen and I am audible. Is that clear?
You are audible, sir. You can share your slides. You can have approximately, you will get easily 30 minutes. I am sure you can take time, sir. Yes, sir.
See my slides very well.
Sir, slides are not yet visible, sir.
Slides
Sir, please share your screen, sir.
1 minute. 1 minute. Okay. Okay, I'll share the screen. Yeah, I'm sharing. Hello?
Yes, sir.
Can you see slides, Hafiz?
No, sir.
No, sir. Sir, first click on that share option.
Okay.
Yes. After that, you can see entire screen option.
1 minute. I'll say slides, share the screen.
Yes, sir.
Once, then?
After, click on that entire screen option, sir.
Okay, entire screen.
Yes, and then share.
And share. Right? Okay.
Yes, sir, it's coming.
Yes. Please open your slide, sir.
Can you see now?
Yes, sir. Please put it in full screen.
Slide show mode. Yeah, perfect, sir.
Okay, thank you very much. So sorry for this technical troubles. So today we are discussing something like a shoulder dystocia. See here, from a normal bridge, when big truck is passing, what can happen? The bridge also can get damaged, the truck also can get damaged, or both can get damaged. And this is what is the story of shoulder dystocia. Right? So it's an unpredictable, unpreventable at times obstetric emergency that causes maternal injury and fetal injury too. It's one of the most important clinical and medical complication of vaginal delivery if it happens. The incidence ranges between 0.7 to 1.7%. Recurrence rate is between 1 to 22%, pretty high if the previous pregnancy is having shoulder dystocia. And when you see the definition, RCOG has defined beautifully, when the fetus has vaginal cephalic delivery, but the shoulder does not deliver spontaneously or with normal amount of gentle downward pressure, we call it as a shoulder dystocia. Or by Sponge, the was given definition in 1995, if the delivery of the body takes more than 60 seconds after delivery of the fetal head, body in the sense the shoulder, it is called as shoulder dystocia. And this can happen because of the disproportion between the big bisacromial diameter, which is more than 14.5 centimeter of the fetus, and the AP diameter of the pelvic inlet is definitely less. Rather, no diameter in the pelvis is 14.5 centimeter. They range between 10 to 13 centimeter, and obviously a larger bisacromial diameter cannot enter, cannot pass, and that's the story. The diagnosis depends on the failure of the shoulder to deliver after the head with gentle traction. Head to body delivery time is more than 1 minute. Need for additional obstetric manuals to deliver the shoulders. Classical turtle sign, the retraction of the fetal head against the perineum after the delivery, and absence of normal restitution of the fetal head, which is supposed to occur after the delivery of the fetus. You can see this beautiful turtle sign. The baby's head has come out and again it is going to retract it back, and that is called as turtle sign, which classically diagnoses it. It can happen with one shoulder or both shoulder. So we can call it as a unilateral shoulder dystocia. The anterior shoulder is behind the pubic symphysis and obviously posterior is in the sacral hollow. Or both the shoulder, they are above the pelvic inlet, above the pubic symphysis, and obviously this becomes bilateral shoulder dystocia. So many risk factors are there. The factors lack specificity, only 20% are sensitive. Obviously, one of them is macrosomia, big baby. There is a relationship between the fetal size and shoulder dystocia, but it's not a good predictor. Most shoulder dystocia can occur if the fetal weight more than 4 kg or more than 4.5 kg. In fact, this, as I told, only 20% are sensitive, because we even delivered a 4.5 kg baby vaginally without any problems at times in a multi-para patient. GDM is another factor where the baby is macrosomic, big one. Greater shoulder head circumference ratio because the insulin sensitive nature of the tissue that contribute to the shoulder girth compared to the brain bone, and which is not affected neither by hypoglycemia nor by hyperinsulinemia. Next is maternal obesity. Big mothers, BMI more than 35 kg, weight of the patient more than 90 kg, the risk is 0.6%, and weight of the patient more than 100 kg at the time of delivery, the risk is practically 5%. At the same time, we calculate the body fat index of the fetus. When it is more than 0.88, the risk of the shoulder dystocia is much more one. Postpartum pregnancy, yeah, I agree. Postpartum pregnancy was upon a time that do cause something like a shoulder dystocia. We call this as a triple tragedy in the obstetrics. She was the Princess Charlotte of the Wells, who had postpartum pregnancy. She was induced for the labor, which lasted for 50 hours. Baby died during the process of delivery. She had PPH with pulmonary embolism, and she also succumbed. The peer pressure of the royal family, Dr. Richard Croft, rather Sir Richard Croft, couldn't sustain, and he committed suicide. So baby died, mother died. The doctor who conducted the delivery or obstetrician conducted the delivery, Sir Richard Croft, also died. So it was labeled as a triple tragedy in the obstetrics. Today we hardly see, absolutely rare. Even a 1 day more than the expected date of delivery, entire family rushed to the clinic. Sir, दिन ऊपर चढ़ गया है, expected date of delivery obviously cross करवा दिया है. Now please deliver her. You can do cesarean now. I think from their side, the family and patient side, this is one of the big indication they are pursuing to the doctors. It has crossed the EDD. Please do a section. I do agree. All postdatism doesn't be a big babies, but yes, some of them definitely with weight more than 4.5 kg. Length of the baby more than 54 centimeter, biparietal diameter more than 10 centimeter, and bisacromial diameter more than 15 centimeter. All these 4 parameters, we call it as a Finn-Bose criteria to diagnose the big baby of postpartum. Hardly we see. Excessive weight gain in the pregnancy with sedentary life habits, more than 15, more than 20 kg. do contribute for a big baby and shoulder dystocia. Previous shoulder dystocia, definitely the risk is much more, practically 22%. Obviously, there is no role for elective induction, no role for C-section also, but obviously previous shoulder dystocia, you have to individualize the affair depending upon the patient. Shoulder dystocia, difficult to predict. 50% occur in absence of the risk factor. That is one of the big story. So many complications can occur because of shoulder dystocia. We are going to see the manuals afterwards because I have kept all the videos one after another. It can cause fetal asphyxia, it can cause brachial plexus injury. Most common is in this most common injury in 5 to 15% of the cases. The common type is earth palsy, involves C5, C6 nerve root, the superficial damage to the nerve by stretching, the neuropraxia injury, causes classical vater stiff position to the hand of the baby. Or sometimes a lower C8 and T1 can get even stretched with neuropraxia injury. Nerves doesn't get traumatized completely. The superficial nerves, covering of the nerves, the sheath of the nerve that get damaged, and that can cause the Klumpke's palsy, which classically claw hand. Extension at the wrist and flexion at the fingers, a classical claw hand deformity in Klumpke's palsy. All of them they resolve without any permanent disability in more than 80% of the cases. 6 to 10% may have little disability. And this is one of the reasons sometimes for a big baby delivery is for litigation. Humerus fracture in 0.1 to 4%. Clavicle fracture in 1.5 to 10% of the cases, obviously. And so many maternal problems. These are the fetal ones which you have seen. And these are the maternal ones. Genital tract laceration, OASI, obstetric anal sphincter injuries, third degree and fourth degree perineal tear, involving the anal sphincter when you deliver such a big baby. Obviously, when it is not supported properly by your assistant. Extension of episiotomy, even up to the posterior fornix, sometimes we call it as a gutter episiotomy. Postpartum hemorrhage, usually traumatic one. But yes, when you deliver such a large baby, large placenta, big amniotic fluid, uterus may not contract properly, can have uterine atony. And this happens because of prolonged labor, large infant, large area of the placenta, and large sinuses which they are there, which are able to contract properly, and the patient can have bleeding, traumatic plus atonic all. And obviously, the patient definitely we have to induce repeated internal examination, may contribute a little infection to the patient. Now, what's the management? Most important thing, do not be panic. Obviously, no panic. Do not press the panic button. Do not give traction or pull to the baby's head. Most important. Do not apply the fundal pressure, which is a very classical, traditional Indian. You can say the traditional birth attendance technique. Push the fundus, try to deliver the baby, not by the doctor. Because we always say in the labor room, don't give any fundal pressure. That's not supposed to be given. Some labor rooms, even we have seen some attendants sitting on the tummy of the patient and trying to push the baby. We know this fundal pressure can cause a lot of problem to the baby, to the mother, and at times to the splenic rupture also we have seen, and it causes intractable hemorrhage in the abdomen. So not to be given, do not apply fundal pressures. Quick systematic approach is there. Avoid 4P. Avoid panic button, avoid pulling, and avoid pushing, and avoid pivoting to at the same time. Call for the help. Evaluate the episiotomy, evaluate the patient for episiotomy, evaluate the patient whether she's having unilateral, bilateral. L for legs, that is the Mac-Roberts maneuver which we are going to see. P for suprapubic pressure. E for internal maneuvers, that's internal rotation, and R for removing the posterior arm. And R is the roll the patient in all four positions. So we call do the helper HELPERR and avoid 4Ps. That's called as a quick systematic approach to manage and to treat the shoulder dystocia. Now, what maneuvers they do for shoulder dystocia? Most important thing, they do three things. One, they decrease the bisacromial diameter of the fetus, little compression of both the shoulders. Yes, slight reduction, maybe by 1 to 2 centimeters, beneficial for delivery of the baby. Rotate the fetus into wider oblique diameter. We know 11, 12, and 13. 13 is the oblique one. If you rotate the fetus into or shoulders into wider oblique diameter, easy to descend, easy to come out, and that's what we are going to have. And the last one is increase the functional size of the bony pelvis, which is achieved by some manuals, definitely. And all these three things in one will, when they increase the diameter of the pelvis, decrease the diameter of the shoulder, It will be easy for the delivery of the arrested baby, we call it as maneuvers for the shoulder dystocia. So many techniques are used. Yes, macrobeds is the first one. Definitely used all over the world. Even today, everywhere in India, the first thing everyone wanted to do is macrobed. Then Wood's corkscrew maneuver, Rubin's maneuver, Gaskin's maneuver, and Zavanelli's. These are the 5 important maneuvers which are going to be done to manage the shoulder dystocia cases. William Alexander McRoberts Jr., American obstetrician and gynecologist, first to publish the supine hypotensive syndrome. He invented this McRoberts maneuver, and to be very much frank enough, this is the first line procedure in shoulder dystocia management. What is this one? You can make out the beautiful video here. Sorry, this is the throat creating a trouble for me. Now, extreme flexion of the maternal thighs to the abdomen. Flatten the lumbar lordosis. Straighten the sacrum. Rotate the pelvis cephaloid and elevate the pubic symphysis. Change the orientation of the fetal shoulder from AP to oblique. Free the impacted anterior shoulder without increasing the pelvic diameter. And you can make out the baby is smoothly going to be delivered here. In McRoberts, all 3 things. 1, the AP diameter also increases slightly, yes, by at least 1 to 2 centimeter. It flattens the lumbar lordosis and straightens the sacrum. It rotates the pelvic cephaloid and elevates the pubic symphysis, again help to increase the diameter by 1 centimeter. Change the orientation of fetal shoulder to the oblique, obviously 13 centimeter. A brick broader diameter is involved here, and free the impacted shoulder and deliver the baby. Most beautiful maneuver, successfully conducted, and this is the McRoberts. Coming to the Rubin's maneuver, Alan Judah Rubin, again an American obstetrician and gynecologist. He remembered for his Rubin's maneuver, managing shoulder dystocia, which he invented in 1964. See the beautiful video of the shoulder dystocia Rubin's maneuver. Suprapubic pressure is given without vaginal manipulation. Yes, acts on the posterior surface of the anterior shoulder. Push the shoulder towards the fetal chest, a little reduction in bisacromial diameter. Adduct and reduces shoulder width. Facilitates the delivery of the or descent of the anterior shoulder, and you can make out smoothly the baby deliver. The next maneuver we always say, first McRoberts, second one is the Rubin's, absolutely helpful for the patient to deliver vaginally in shoulder dystocia. Then comes the Woods maneuver. Charles Edwin Woods, American obstetrician and gynecologist. Woods screw maneuver, a technique used in the management of shoulder dystocia. Absolutely beautiful video, self-explanatory. Vaginal hand placed on anterior aspect of the posterior shoulder. Pressure applied in a rotational direction rather. The fetal trunk rotates like a screw, 180 degree of the posterior shoulder rotation. The shoulder diameter converts into oblique. The impacted anterior shoulder is released smoothly, you can make out here, and the baby is going to be delivered anterior first, and the posterior shoulder is coming out of the outlet of the pelvis. Then Inami Gaskin's maneuver. This lady, she is an American midwife. She is not a doctor, but yes, she contributed a lot to this particular shoulder dystocia. We call it as a Gaskin's all-4 maneuver, which she invented in 1977. Beautiful video for the Gaskin's maneuver. Mother is turned to hand and knee position, absolutely. Pelvic dimensions and orientation change. The fetal weight is going to press against the pubic symphysis, stretches the ligament and outlet by 2 centimeters. Gravity assists the shoulder descent. The posterior shoulder often deliver first and anterior shoulder that follow the spontaneous delivery. You can see this beautiful maneuver in this particular video. Yes, the posterior shoulder, which was near the sacral promontory, came first, then the anterior shoulder behind the pubic symphysis, and baby is delivered by Inami Gaskin's maneuver, that is all 4 limbs. Then comes Zavanelli's maneuver. William Angelo Zavanelli, American obstetrician and gynecologist. When everything fails, what can be done? A cephalic replacement as a last ditch effort to overcome the probable bilateral shoulder dystocia. Yes, when it is bilateral, Zavanelli is the best one. Followed by caesarean section, that's the Zavanelli's maneuver. You can see here the beautiful video of the Zavanelli's maneuver. has to be done under terbutaline or subcute, or it can be done under the NTG patch. The cephaloid replacement of delivered fetal head back to the vagina, achieved by the flexing the fetal head to the reverse extension. Convert the vaginal delivery back to the intrapartum cesarean section, has to be done in operation theatre only. Temporarily release the shoulder impaction by undoing delivery sequence and followed by the cesarean section on the table. The operation theatre maneuver, 7 release maneuver under anesthesia, whatever, if they are there, available there, or they have to be available because we have to do a C-section. Terbutaline or NTG both can be used. Last two things as a resort. Glidotomy. Obviously, when baby is dead, the clavicle of the baby can be cut with a sharp scissor. Obviously, the large bisacromial diameter collapses and baby can be delivered. Preferably, we use for the dead fetus, not for a live one. And symphysiotomy, tried for a long time in past, which increases the diameter, all diameters of the pelvis by more than 1 to 1.5 centimeter, and delivery of this impacted areas or parts can be achieved very well. Most important thing now, what's the safety of the doctors in view of the litigation days? Keeping the birth record properly. Time of the delivery of the head, mentioned properly. Time of the delivery of the baby, mentioned properly. Anterior shoulder at the time of delivery, again time mentioned properly. Mention the manners they have performed, their timings and the sequence, how you have done it. Maternal and maternal, perineal and vaginal examination has to be done to check whether it is third degree tear, extended episiotomy, and obviously you have to record it properly. What you need to do when such situation can come in the labor room? Rehearsal, drill of macro hours can be done even with a normal size weight baby. Yes, you can try it. Normal weight, normal pelvis, just a small thing. When you find out there's slightly a delay in the delivery of the fetal shoulder after delivery, you just can do a rehearsal drill of macro hours so that you can do it properly when the time comes actually. So in conclusion, prediction and prevention absolutely difficult for shoulder dystocia. Can occur in any delivery. You have to individualize the maneuver, individualize the management of the patient, and what you need, a good communication. Good communication with your colleagues, with anesthesiologists, with pediatrician, with neonatologist, and with the relatives of the patient who are standing with patients or without patients outside the labor room. Good documentation, most important one, and good skill to deliver. What's the aim of this ICOG and FOGSI combined PG series is the transmission of the skill and knowledge. A proper transmission of the skill and knowledge to the postgraduate student who can tackle such condition in the future on their own and can prevent the maternal and fetal trauma and have an easy vaginal delivery. That's it. At the same time, the prediction, I always say, you require a good sonologist, good fetal biometry, good estimation of the expected birth of the fetal weight, most important thing, estimation of the fetal body fat index, and estimation of the bisacromial diameter, biparietal diameter of the baby, a thoracic diameter of the baby, thoracic circumference of the baby, abdominal circumference of the baby. And this is the one with good sonologists you can very well predict that when baby is bigger in size, you can probably plan either elective section or you can be ready in the labor room when you wanted to go for a roomy pelvis trial for vaginal delivery for this condition. So thank you guys for patience listening. Thank you ICOG, thank you FOGSI, thank you Ashok Bhai, thank you Hafiz, thank you Ashish Bhai, thank you Sheila Mane Madam, and thank you all the people who joined this particular ICOG PG.
Just a minute.
Thank you, everyone.
Just hold on and just give my comments.
We are having since yesterday John Hopkins team with us in our institute. If you can permit me to leave the thing, please leave the session. I'm stopping this, and please permit me to leave the session, guys. Thank you, everyone.
Hello, thank you so much, Dr. Hemant Deshpande.
Thank you.
Hemant, as I know, from long ago, he was a very a dynamic chairperson of the Medical Education Committee of FOGSI, and I have been involved with him in many activities. And equally dramatic was his presentation today, and I think this has left a permanent impact in the students' mind.
Thank you.
And so useful because of the condition is also dramatic, like shoulder dystocia. I thank Hemant because of his emphatic presentation. He's always very dynamic in his presentation. And I think this, how to tackle this.
Can I just
Yes,
add something, Dr. Ashish?
Yes, Sheila Madam, yes.
See, actually, there is a documentation form for shoulder dystocia. Once it happens, it should be there, because as you said that the medical legal cases are more maximum. And it is very important to mention that which was the anterior shoulder, which was posterior, whether it was a right or a left. Because sometimes intrapartum prolonged labor also, if the shoulder is hinged behind the symphysis pubis, can result. So for medical legal purpose, again, that will help, and documentation also. So that documentation form has to be there in every labor room if the shoulder dystocia happens. So that the events, that after how many minutes or seconds you did this maneuver, then that maneuver, and that will really help. So that is just one additional thing I just wanted to say, because we do come across medical legal cases in Bangalore.
Thank you.
Yeah.
Thank you. Well taken.
Thank you.
Thank you, madam. Thank you.
Thank you so much, Samantha Deshpande sir. It has been a very exciting presentation, and as we expected, I am sure this will have a long-lasting impact on the postgraduate students, and it will also be there in our website, as we have initially said. It will be on record, so students can go later on to this, and they can enrich their knowledge on this topic, important topic, as well as enhancement in practical knowledge. Ashish sir, can you move to the second session, or any further comments?
I don't think that any further comment is there. So
yes.
I think we will straight away move to Professor Maji's session.
Okay, sir. So we'll move to our second session, another important session that is on a case discussion, which has been a regular feature in our PG clinic in the last 5 years. So we try to bring students or colleges from different parts, and we keep on changing the colleges, and this gives the students from different parts or different colleges an opportunity to present, as well as the faculties from the different parts. So this month we have students from GMERS Medical College, Sola, Ahmedabad. We have students from there. They are going to present a case on recurrent pregnancy loss, and we have our galaxy of expert faculties with the expert Dr. Ashish Kumar Mukhopadhyay sir. Sir is principal and professor at CSS College of OBGYN and Child Health at Kolkata. Then we have Dr. Shailaja R. Bidri. So Madam is professor and head of OBGYN at BLDE Sri B.M. Patil Medical College, Vijayapura, Karnataka. We have Dr. Uma Pandey, another expert professor of OBGYN at Institute of Medical Science, Banaras Hindu University, Varanasi. We have Dr. Rujuta Fuke. Madam is Associate Professor of OBGYN at GMCH Nagpur from Maharashtra.
Hello, everyone.
Then we have Dr. Gotthard Doke. So Dr. Doke is Associate Professor of OBGYN at Tomo Riva Institute of Health and Medical Sciences, that is Arunachal Pradesh. I'd like to request Dr. Mayur Gandhi sir to kindly introduce their students for their presentation. Dr. Gandhi, are you there?
Yes, sir. Very good morning to one and all. My two students, Dr. Shivangini Mehta, who is third-year resident, and Dr. Vartika Kumari, who is also a third-year resident, they are going to present a case with a history of recurrent pregnancy loss. Thank you, sir.
Okay, so I'd like to request Dr. Shivangini and Dr. Vartika to please share your screen. And I'd like to, at the same time, I'd like to request our faculties, Dr. Ashish sir, Dr. Shailaja Madam, Dr. Uma, Dr. Rujuta, and Dr. Gotthard to kindly take their long case for the today. So over to you, students, as well as the faculties.
Thank you, Hafizur. Before we start the presentation by the students, let's have a short overview of what we are going to do. We have been doing this for the last 5 years, but just for reiteration for the new faculties and the students. So we will allow the student to, complete the presentation first. Whatever the way they have written it, they will present first. And then once they complete their presentation, we will ask all the faculty members involved together one by one, and then go back to the slide number 1 and start crossing on the history part first. So we will cross on the history part first, followed by the examination. Then we will do the investigations, differential diagnosis, and the management. So this is the way we will proceed. And while they are presenting, we should not interfere in their presentation. That is the usual way the examination goes on. And that's what we have been doing for long years here in ICOG. And then after investigation, we can spend time on management from basic to advanced level. We'll go step up process, and also in the end, summarize and close. So this is our suggested short way how to do it. And I would like to request both our students, Shivangini and Vartika, to start sharing your presentation. Yes, Shivangini. I think their connection is interrupted or what? Hello?
I think the technical team to check.
Hello, ma'am, can you hear me?
No, students, Shivangini, they are there, Vartika and Shivangini. I can see.
Hello, Shivangi ma'am.
They have lost their connection, it seems.
No, they are connected, showing, sir.
Okay, they have lost voice or what? I don't know.
Hello, Vartika ma'am, can you hear me?
The video is also not visible.
Dr. Gandhi, sir.
Yes, sir.
Can you check with the students?
Yeah.
Yesterday also I had same problem.
Sir, there is a problem in the connection. So they are trying with the another laptop.
What happened? I think both of them will be having some system. If they are in institute, they can take somebody's help.
Can you please share number, sir, so we can direct contact with?
Hello, everyone.
Hello,
Happy
ma'am.
Women's Day. Hello, officer.
Welcome,
Happy-
Shobha.
I think
I have a talk with them. They actually they hang to the computer once they are studying, but they are fixing the issue, ma'am. It's very soon. We tried with them the other day, Friday. It was absolutely fine with their connection and everything. Friday evening we had it.
they should be able to present the case report without looking at the screen, or just being on the screen. That
Maybe.
also helps. Yeah.
Maybe, ma'am, that from the next time we'll prepare them like that with a
No,
paper and
now they
like
can
that.
start presenting while they are fixing it. They can start presenting also.
In the
That's what-
examination, they does like that way. Maybe from next time we have to prepare them like that way as well. But it's more of a like for
Okay,
convenience
fine.
of the faculties
I
that they
think
can have a.
Hafizur, let us
Yes,
discuss all these things later. First, see to it that they log in. We are wasting time.
They have logged in. They have logged in, I think.
Yeah.
Shivangini, please start.
Yeah, please share the screen and start.
Hello.
Yeah, go ahead. Please share the screen and start presenting.
Yes. Good morning, everyone. Sorry for the delay. I'm Dr. Vartika Kumari, and this is my colleague, Dr. Shivagini Mehta. We are doing a case presentation on history of recurrent pregnancy loss. So, starting with the case, our patient, Mrs. X, is a 26-year-old female.
Share the screen. Share the screen. We don't see your screen.
Ma'am, please click on that share option, which is green color, in the bottom side. Hello, can you say it, ma'am?
Yes, ma'am. Yes.
Okay.
Is it coming?
Yes, now visible your screen. Please put it in full screen, ma'am.
Slideshow.
Yes, slideshow.
So our patient is Mrs. X, 26-year-old female. She has studied till 8th
Sorry
grade.
for interruption, ma'am. Right now your slideshow mode is not on.
Make it full screen.
First click on that enable editing option.
Slideshow. Make a slideshow, beta.
Yes, ma'am. It's on slideshow.
For us, it is not. Anyway, you proceed. We are.
Enable Vartika, ma'am, please click on that enable editing option.
That yellow bar.
Yes.
Yellow bar enable editing.
And now you make it full screen.
Ma'am, right now your slide is not visible. Vartika, ma'am.
फिर से कर लीजिए.
Please share again.
Is it visible now, ma'am?
No, ma'am. Ma'am, again click on that share screen option.
Slideshow.
Yes.
Is it visible,
Perfect,
ma'am?
ma'am. Yes, ma'am.
Go ahead.
Sorry for the delay, ma'am. So our patient is Mrs. X, age 26-year-old female. She has studied till 8th grade and is homemaker by occupation. She is a Hindu residing in Chanlodia area in Ahmedabad, which is 4 kilometers away from the hospital. So she belongs to lower middle socioeconomic class according to modified Kupuswamy classification. Patient came to our labor room at Solar Hospital on 2nd Feb 2026 at 7:30 p.m. with history of 9 months of amenorrhea with lower abdominal pain since 1 day. Patient complained that the pain was of intermittent dull aching type in nature, non-radiating, not increasing with frequency, duration, and intensity, and was relieved by analgesic. There was no history of leaking or bleeding per vagina, no passage of show, no history of nausea, vomiting, and constipation, no history of fever, burning, micturition, or urinary complaint, no history of trauma or recent intercourse, no history of headache, blurring of vision, epigastric pain, or foul-smelling vaginal discharge. According to her menstrual history, her last menses was around 18th May 2025. According to Negle's formula, her expected date of delivery is around 25th Feb 2026. Her gestational age, according to the LMP, was 36 weeks, 4 days. According to her past menstrual history, she has 3 to 4 days of menstruation in 28 days cycle. And, her cycle is regular, moderate, and painless. Coming to obstetric history, patient has been married for 8 years. The marriage is of non-consanguineous type. Patient's obstetric score is Gravida 4, Para 1, so 2 abortion and 1 live-in. So her first pregnancy was in the year 2019. During that pregnancy, she took 2 antenatal visits, which were uneventful, which was followed by a full-term vaginal delivery at home. There's no postpartum visit taken after the delivery. And she delivered a healthy male child of 7 years, which is currently living. The birth weight of the child was 2.3 kilos. and the child cried immediately after the birth and was breastfed exclusively for 6 months and is immunized till date. After that, there's a history of first abortion in year 2022. She took one antenatal visit during that time. She complained that there was spontaneous expulsion of fetus after she had vague back pain and leaking per vagina. The event was not followed by dilatation and evacuation, and reportedly the abortus was normal looking grossly. Then abortion was in year 2024 by UPT at home. Again, patient complained that she had months of amenorrhea. It was not followed by dilatation and evacuation, and again the abortus was reportedly grossly normal looking. During both the abortion, there was no history of empty pill ingestion, no history of false milk discharge, fever, lower abdominal pain, trauma, or drug intake in both the cases. Coming to present obstetric history, in first trimester, patient has conceived spontaneously and her pregnancy was detected by UPT at home after 2 weeks of a missed period. Patient was booked at private hospital where she took her antenatal visits. Her scan was done at 1.5 months of amenorrhea, suggestive of 7 weeks of intrauterine live pregnancy with normal ovaries and adnexa. She took folic acid tablets regularly. There was no history of excessive nausea, vomiting, teratogenic drug intake, radiation exposure, fever with or without rash, and no history of burning micturition in first trimester. In second trimester, patient had taken the regular antenatal follow-up in the same hospital. She took 2 doses of injection TE 1 month apart. Iron and calcium supplements were started. Patient was compliant for the same. Deworming was done using albendazole tablet, and NT-scan was not done. And during this period, she had cervical encerclage done at 12 weeks of gestation in a private hospital in view of history of 2 painless second trimester loss. Post-procedure period was uneventful. There was no history of bleeding per vagina, leaking, fever, or abdominal pain after the cerclage. Progesterone support was started. Quickening was felt at 5 months of amenorrhea. Anomaly scan was done at 2 weeks, 2 days, showing single live intrauterine fetus with no gross fetal anomaly. Placenta was proceeded and liquor adequate. In her third trimester, the patient continued to appreciate fetal movement well. There are total 6 antenatal visits taken till date. Then her growth scan was done at 32 weeks, 3 days, which showed normal growth. Liquor and Doppler were also normal, and the placenta was proceeded. Tablet, iron, and calcium supplements were taken regularly. No history of rapid weight gain, bleeding per vagina, or burning micturition. In her past medical history, patient did not have any history of diabetes, hypertension, renal disease, autoimmune disease, epilepsy, thyroid disorder, any venous arterial thrombosis event, no history of galacturia. Coming to surgical history, there was no history of any abdominal surgery, no history of any uterine instrumentation or cervical intervention in the past. In her family, there's no history of hypertension, diabetes, tuberculosis, thyroid disorder, any blood disorder. There's no history of recurrent pregnancy loss, preterm birth, or congenital malformation, or any chromosomal anomaly in the family. Coming to her personal history, her appetite, bowel, bladder, sleep remains adequate. She's a non-alcoholic, non-smoker, does not have any addiction to any drug or substance. There's no known case of allergy to any drug or substance. Coming to nutritional history, patient takes mixed diet. Her average calorie intake by 24-hour recall method comes to about 2,000 kilocalorie, and it showed calorie deficits of 250 kilocal for the day. Then her approximate protein intake was of 60 gram per day, which showed a protein deficiency of 24 gram per day for her. Coming to partner history, her husband is a 30-year-old government employee. He is a non-smoker, non-alcoholic, non-tobacco chewer, and he does not have any history of chronic or medical illness.
On general examination, patient is conscious, cooperative, and well-oriented to time, place, and person. Patient is well-built and well-nourished. Her height is 164 centimeter, weight is 76 kg, by which her BMI is 29.7 kg per meter square. There is no pallor, edema, cyanosis, icterus, or lymphadenopathy. On palpation, patient is afebrile. Her pulse rate is 86 per minute, regular in rhythm, good volume in right radial artery. Blood pressure is 114 by 76 mmHg in sitting position in right arm. Respiratory rate is 14 per minute of abdominothoracic type. Thyroid, breasts, and spine appear to be normal. No discharge from the breast. On systemic examination, cardiovascular system, normal S1 and S2 heard. There were no murmurs heard. On respiratory examination, bilateral air entry were present, no adventitious sound heard. On the CNS examination, patient is conscious and oriented. There is no neurological deficit. On abdominal examination, on inspection, abdominal is uniformly enlarged, linea nigra and stria gravidarum seen. Umbilicus is everted. There is no engorged vein or scar seen. On palpation, uterus is 36 weeks pregnant. Symphysiofrontal height is 30 centimeter. Uterus is relaxed. On first Leopold maneuver, broad, soft, irregular mass suggestive of buttocks. On second Leopold maneuver, right lateral grip, continuous smooth curve felt suggestive of spine. On left lateral grip, irregular knob-like structures felt suggestive of limbs. On third Leopold maneuver, smooth, hard, and globular mass suggestive of floating head. On fourth Leopold maneuver, hands are converging, suggestive of unengaged head. On auscultation, fetal heart sounds were heard and were regular, approx 134 per minute on right spino-umbilical line. On vulval examination appeared to be normal. On perspecular examination, cervix is visualized. A non-absorbable suture material is seen encircling the cervix at the level of internal os. The knot is seen anteriorly. There is no bleeding or discharge. No membrane bulging is noted. On pervaginal examination, cervix is soft, uneffaced, and closed. Cerclage stitch is felt in situ. There is no bulging membrane. Summary: Mrs. X, aged 26-year-old, gravida of 4, para 1, abortion 2, and with 1 live child, married for 8 years, was admitted on 2nd Feb 2026 with complaints of lower abdominal pain. Her last menstrual period was 18th of August 2025, and according to her, the EDD was 25th of Feb 2026. So she was 36 weeks, 4 days pregnant. She was antenatally checked up regularly. She has a history of 2 painless spontaneous second trimester loss, followed by cervical encirclage and present pregnancy at 12 weeks in private hospital. On obstetrical examination, single live intrauterine fetus with longitudinal lie, cephalic presentation, and floating head with fetal heart sound heard regular in the right spino-umbilical line and with cervical cerclage in situ. My provisional diagnosis is a 26-year-old gravida of 4, para 1, abortion 2, live 1 with 36 weeks, 4 days pregnancy with cephalic presentation with regular FHS with cerclage in situ with false labor pain with history of 2 painless second trimester abortion.
Have you finished
Thank
it?
you.
Okay, then since their presentation has finished, now I will request all the faculty members, Dr. Shailaja R. Bidri, Dr. Uma Pandey, Dr. Rujuta Fuke, and Dr. Gota Duke. You can now cross them. You can ask your questions if you have noted any points, and the student will go back from the history once again. So go back to the first slide and let the faculties interact on your this thing. First slide, please. We would like to.
A very good afternoon, Dr. Vartika and Dr. Shivangini. It was a very good presentation, and I think you have tried to cover all the main points that are actually essential to take a case wherever there is multiple abortions or a past history of multiple abortions is concerned. So my question to you is that we'll go slide by slide, but first of all, since this is a presentation of a recurrent pregnancy loss, right? So
Yes,
classically, do you agree that this is a case of a recurrent pregnancy loss?
No,
By definition.
Just raise the points which are there in the history they have noted. Do you find any inaccuracies?
Yes, sir.
Yes, sir. In the patient details format? Do you find anything here?
Sir.
No.
Any faculty can interact?
Not, sir. Not in this. Not in this.
Okay. Okay. In my opinion, I think they should also write the date of admission, date of examination here in the patient particulars. And instead of writing Mrs. X for the sake of confidentiality, you can write Mrs. the short name of the patient or the abbreviations. Okay. You may not disclose the full name of the patient.
Okay, sir.
Yes, sir.
And then go to the next slide, please. Go quickly. Okay. Yes. Socioeconomic status is okay. The chief complaint has a way of presentation. You don't write like patient came in labor room, so and so.
But I think Dr. Ashish, Dr. Rujuta had asked one question. Let them answer.
No, ma'am, it's okay. We'll come to that question.
Come to the question. First,
the flow of the presentation.
Whether they have made it right or not. Isn't it?
Okay. Yes, sir. Yes, sir.
That is our discussion. Yeah. Okay.
Yes, sir.
So write the chief complaint differently. Okay. So
Okay,
just like plain and simple pain in lower abdomen with 9 months of amenorrhea. Okay. There's no need to write patient came in labor room at Solar Hospital later on. That is a history of present illness. Okay, next slide.
Okay.
Yes. Any comment on this slide? This is okay. Okay, next slide.
Previous slide, she has to come with the history of 9 months amenorrhea.
They have written that. Yes.
Abdomen, sir.
Ah.
Previous chief complaint, patient come with the labor room, no need to write. You have to come with the history of 9 months of amenorrhea, whatever amenorrhea she has come with. And complaints, chief complaint is pain abdomen. That way you have to write.
Correct. Next slide. Yeah, history of presenting illness is right. There's only one chief complaint, but you should add amenorrhea somewhere here. Okay.
Okay, sir.
Okay, next slide, please. So there are a lot of negative histories and they have bearings with the labor pain or other types of pain with the patient. Okay.
Yes.
Anything else you want to add or subtract from here? Any faculty can comment?
Only the pain should have been described well. It was written patient comes with the pain in Sola Hospital, and then next slide says that the pain was not like labor pain. It was like not increasing in frequency. So this pain should have been more specified as
in
far
detail. Okay, they have tried. They have a bit more, 1 2 points maybe added.
it's
Yes.
like more of a surgical pain. It's like so.
So even now, as we look up here to day 9 of the conflict.
There's some background noise. Please mute. Next slide, please.
Western boy, all no, so that is okay.
Okay, next. I need all the faculties to interact. If you note any point, just point it out to them. They will correct it.
Yes, sir. Yeah.
This so appears.
Here in menstrual history, I think they haven't written about the cycle. They have written in 28-day cycle. That means in Nigeli's formula, this is correct only when the menstrual cycle is regular. So that's important. And LMP, you should write somewhere the patient is sure about the date. These 2 points I'll add. Here.
So do we...
Sir, 1 second. We add the age of marriage also here.
Yeah, Dr. Bidri, yes.
No,
Yeah,
age
Dr. Sir, should we add this
in our
LMP
process.
and EDT in this menstrual history? Usually it is given in...
Usually, usually we don't write LMP EDT here. LMP you should write, but EDT, okay, it doesn't matter. If
But people do write nowadays this in menstrual history. They do.
Okay.
Usually we advise them in present obstetric history.
We
obstetric
do.
history,
We
gestation
have
age.
read in obstetric history, but trends have changed now.
Yeah. Next slide, please. Yeah, this is obstetric history in the past. They have described each and every pregnancy details. So I think it is okay. So 2 pregnancies.
Marriage, the spelling must be corrected. Miraj. That needs to be corrected. It's very important event in your life.
Okay. Marriage.
Tick कर दीजिएगा घर जाके.
Sir.
Okay, sorry.
Okay, that's okay.
वो बोल नहीं रहे क्या करें.
Sorry, ma'am.
कोई बात नहीं, घर पे जाके ठीक कर दीजिए.
Yes, ma'am.
Apart from that, things are fine.
Just a second, wait. Abortion, abortion one, they did mention about the place of, was it taken to hospital or home? No, first, A1.
Yes, sir. It's not written for A2 as well.
Yeah, exactly.
One more thing. And one more thing I would like to add here. Whenever there is second trimester abortion, whenever there is second trimester abortion is concerned, so we have a chance. See, we have this fetal tissue available to us in the form of placenta and all. So we can easily send fetal tissue for examination. So that is one thing. Because in first trimester abortion, so you should have mentioned whether that was done. If it is not done, then that's okay. But if it is done, whether it was done or not, that is important. The mention
Yes,
is
ma'am.
important.
Yes, ma'am.
Because in first trimester abortion, okay, we have to wait for 3 consecutive abortions to send the fetal tissue for karyotyping and all. But in this case, you can send. It makes sense. It's the second trimester abortion.
Yes, ma'am.
Yeah, clearly not the case, suggesting
Ashishta?
that the pedestrian does not have control.
Yes, Shobha.
Yes, sir. Good morning. मैं एक पॉइंट कर सकती हूँ क्या यहाँ पे?
डेफिनेटली बोलिए ना.
About the obstetric history and before that in the history of presenting complaints, हम लोग ये सिखाते हैं कि amenorrhea is a physiological symptom. So we say history of amenorrhea of this duration with the following complaints. Then it becomes easy for them to say the complaints. अच्छा ये जो obstetric history है इनका, I think we should strongly propagate that the very second loss, whether first trimester or second, must be subjected for examination and preferably a genetic evaluation. Even if resource poor, a list should be made of what is the test which needed to be done. I think so, because to wait for a third loss is no longer acceptable. Second loss onwards, we must investigate. So maybe we should give them the correct message. Second loss onwards. So the moment there is a second loss, a complete investigation of the abortus should be done. And in this case, since it was missed, maybe then the next point of contact, at least the parental karyotyping should be done. So maybe that is there.
Yeah, so that applies to second
We will
trimester
discuss
abortion.
this in the management issues.
Thank you.
There is some background noise I can hear.
कई
Please.
तरह का है noise.
Okay. Hafiz, are you there?
Yes, sir.
You ask individual faculties to respond, please.
No, sir, you can tell the faculties, those who are part, they can.
सर नेक्स्ट स्लाइड पे चले हम लोग.
चले.
नहीं वर्तिका
Yes.
नेक्स्ट.
Yes, sir.
नो हिस्ट्री ऑफ बोलो पढ़ो.
There's no history of
MTP. Okay.
There's no history of MTP pill ingestion, no history of foul-smelling discharge, fever, lower abdominal pain, trauma, or drug intake in both the abortion event.
Next slide,
Already
please.
you have mentioned about the spontaneous abortions, no, both.
Yes, ma'am.
Yes.
Painless.
Yes, ma'am.
Vague abdominal pain. Okay, fine. Next slide, please.
In present obstetric history, in a first trimester, patient has conceived spontaneously. Pregnancy detected by UPT at home after 2 weeks of a missed period. Patient was booked at a private hospital, and the pregnancy was confirmed by the scan done at 1.5 month of amenorrhea, suggestive of 7 weeks of live intrauterine pregnancy with normal ovaries and adnexa. Patient has taken folic acid tablets regularly. There's no history of excessive nausea, vomiting, teratogenic drug intake, radiation exposure, no history of fever with or without rash, and no history of burning micturition.
One question I would like to ask
Yes.
and Shivangi, whether patient has taken after 2 spontaneous abortions, whether she has taken any treatment prior to conception of this, whether you have taken any history here?
Yeah, patient has not taken any treatment in between the pregnancy. In this pregnancy, she preferred early booking and a number of antenatal visits were increased.
She has not considered prior to conception of this.
No, ma'am.
Pregnancy.
Next slide.
In her second trimester, patient has taken regular
So I would like to add here. You should mention this trimester-wise USG findings in all the trimesters, first, second, and third trimesters. Because obviously this is a case of second trimester abortions. That means we are suspecting either uterine congenital anomalies or something wrong with the cervical incompetence, right? Because because everything is your discussion, the further discussion revolves around the cervical encirclage and everything. So naturally, we are suspecting some kind of a cervical insufficiency in this patient, though she had one previous vaginal normal delivery. So what I want to say is you should ask any procedures that were done to the cervix, like some kind of a cervical trauma. either in the previous pregnancy or some kind of a leap procedures that we do for CIN or any kind of a dilatation or evacuation done, that I think you have asked. And another thing is, because we are suspecting cervical insufficiency, we go for serial ultrasound measurements of cervical length. So that is very important that we start from 12 to 16 weeks. So if not in the first trimester, in the second trimester, you should mention that such and such ultrasonography was done and such were the findings, and she has been subjected to, or whether she has been subjected or not to the serial ultrasound examination of her cervical length. Because there are two kinds of cervical encirclage, the history-based and the ultrasound-based. It's a clear case of history-based ultrasound, history-based cervical encirclage. And we also go for USG-based, where the cervical length is, if it is less than 25 mm, then the candidate is, she's a suitable candidate for cervical encirclage. That we have to make, I think, clear in this history. Okay?
Yes, ma'am. And our patient.
Yeah, let's finish the history and then we will also discuss.
So come to the third trimester. Come to the third trimester. Yeah. So I think everything is okay in the third trimester. Yeah. So I think, and one more point, you should, in all this course of our obstetric or ANC visits, you should take into, we should actually do the counseling of the patient and inform her about her past history, as well as what are the problems she is going to face in this pregnancy, and what are the warning signs and symptoms, and that her education, that medical education should be done for that.
Yes. And all these medical
you have to mention,
although all of them are no, but because of the recurrent loss, you need to still investigate that further. We will come to that in a minute. Carry on.
Yes.
This is no, all no. Carry on.
Okay.
This is also all no.
So hypertension, diabetes, blood disorders, recurrent pregnancy loss. Right. What is this?
Right.
Personal loss.
So personal history. Yeah. So alcohol, caffeine, smoking. These are very important because these are directly related to the pregnancy loss, right?
Yes, ma'am.
Caffeine intake is also very important. You should ask.
Definitely, ma'am. Yes. Next slide, please. Nutritional history. I think we have discussed, but you can do it again.
Yes. No, fine. Partner history this is also fine, right?
Although he was only 8th class pass, but he has a government job. I'm surprised. Anyway, next slide, please. Examination. Who is going to do examination? The same doctor, or you're going to change it?
Change it.
Previous slide, any medication history? Anything on the... I could not see any medication, progesterone in your second trimester.
That is there in the
Yes, sir.
Progesterone was started.
Yes, sir. Progesterone was
after cervical circulage.
Okay. Fine.
It is coming, sir. Okay, examination. Carry on with exam, please.
Patient is conscious, cooperative, and well-oriented to time, place, and person. Patient is well-built and well-nourished. Height is 164 centimeter. Weight is 76 kg, according to which her BMI is 29.7 kg per meter square.
So anything abnormal in this regarding her BMI? Is there any abnormality?
Yes, ma'am. She is obese.
Yeah, she's chubby.
So is there any role of BMI and recurrent pregnancy loss?
Yes, ma'am. With increasing weight, there is 58% chances of recurrent pregnancy loss.
Yes.
Because there is increased chances of polycystic ovarian syndrome, then increased chances of diabetes.
So this is before. This is her pre-pregnancy weight, right? 76 kg is her pre-pregnancy weight, not the current pregnancy.
Current pregnancy weight.
This is when patient came
so you have to ask her pre-pregnancy weight as well.
Yes.
Because the BMI, whatever BMI is there, in the pre-pregnancy, if we consider pre-pregnancy, that is important. That is going to actually put her at risk.
That is very right that you should know the pre-pregnancy, but you have no pre-pregnancy weight knowledge, then you can use this. But it is very true that you must always consider pre-pregnancy weight. Okay.
Yes, ma'am. Her pre-pregnancy weight was 68. We didn't mention it. Sorry.
Then you could have.
Okay, so and you should also mention the weight gain during pregnancy. Yeah.
Yes, ma'am.
Come to the next slide, please. Yeah, this is okay.
There was no paler
Next.
edema sign of. Okay.
No.
Was there, and that's why you have just skipped. All of them are fine.
Yeah, there is no need to read out the entire slide. They've already done this. Just keep it for some time. The faculty.
But the only thing I'm worried that you have written no discharge from breast if the woman is pregnant by 36 weeks. There would be something, isn't it?
Ma'am, the normal pregnancy changes of breast were appreciable, but there was no discharge present.
Okay, okay, accepted. Okay. Usually there is, but that's fine.
Yes.
Next slide. That we have read. Next slide, please. That is fine. It's all normal. Abdominal examination. Okay. Linea and stria. At what gestation both of them would be apparent on the tummy? Primary or multiple?
Linea nigra is in the primary. The linea nigra is a sign of a present pregnancy, and stria gravidarum is the sign of excessive stretching due to damage to the collagen tissue. It's a sign of pregnancy.
Stria is once formed. It's there, isn't it? Those girls who are chubby, they have a stria here. They have a stria on their thighs. So a stria, this is her 4th pregnancy, isn't it?
Yes, ma'am.
So we have to be kind of umbilicus. Why umbilicus would be everted? I mean, she's pregnant. Is it the reason you are saying it is everted?
Yes, ma'am. She is 36 weeks pregnant. That's right. It is stretching of umbilicus.
Everted, I'm not sure about that. Okay, then no English vein or scar seen. Next slide, chaliye, please. अच्छा, यहाँ पे मैंने ये point note करा था that uterine size is 36 weeks and symphysis fundal is 30 centimeter, and you are not worried about that apparently. I would be worried. Outpatient.
Head is also unengaged.
Yes, sir. Yes, sir.
Yeah.
Definitely, sir. I would be
36 centimeters,
FGR.
30 centimeter and head unengaged. So I don't know what.
That means
something is amiss here. See, symphysis fundal height is directly related to the gestational age, kind of, right?
Almost, yes.
And also you can, find out the estimated fetal weight from symphysis fundal height. So you should have done that with this formula, right?
Yes, ma'am. We have done it with Johnson's formula. It was 2.3 kg.
Okay.
Yes.
So at 36 weeks, 2.5 kg, a little bit worried about the FGR because 36 weeks uterus and centimeter for symphysis fundus, that itself indicates that the fetus is FGR.
Yes, definitely.
Yeah.
बाकी तो ठीक है, वो सर ने already point आपको कर दिया था, डोके सर ने, regarding that the head is free floating and SFH is 30, so that is a kind of a significant examination finding. You have to be very careful about that. ठीक है?
Yes, ma'am.
चलिए आगे चलें.
Okay. So are you really able to see this per speculum examination, the non-absorbable suture material?
Yes, ma'am.
Okay.
It will be seen in McDonald. The McDonald.
Yes, वो दिख जाता है, उससे मुझे उतनी आपत्ति नहीं है जितनी आपत्ति है कि आपने इस पेशेंट का पर विजाइनल क्यों करा था. She is not in labor. I mean, आपका ही labor का pain has become like surgical pain. So we don't do per vaginal. We would do per vaginal examination only if we feel that the woman is perhaps going into labor. Speculum is fine. You can do speculum examination. And another thing that we were taught that the knot would be posterior. And why that would be posterior, Vartika? तो टाका जो बांधते हैं हम लोग वो पीछे करते हैं. क्यों?
Ma'am, because if the knot is placed anteriorly and enough retraction wasn't done, it can cause, ma'am, bladder damage,
injury to
bladder.
And if it is placed at 3 and 9 o'clock, then it can cause the laceration over the arteries passing through descending cervical artery at that level. So knot is most commonly placed posteriorly, more likely at 4 or 8 o'clock.
There is another very important reason of my question. Okay. Yes, there is another very important reason why do we do it posteriorly. But if somebody has done it anteriorly and at least they were successful enough in putting a cervical cerclage in a woman who has had two miscarriages in second trimester, it's still they haven't done bad actually. Okay, it is important to help the woman, but also to help rightly. So next slide, please.
Any other purpose of doing per speculum and per vaginal examination in this patient?
Ma'am, per speculum,
At the same time, what can you do, or what should be done, or what if you know if we at any point of time you know that she's either in the false labor pains or she's proceeding in the proceeding for a true labor pains within next 48 hours, what should you do here at this point?
Ma'am, we have planned for cervical cerclage removal as she's already crossed 36 weeks.
Yes.
So that's why we did the
Very
vaginal
important.
examination too.
Yeah. Because if you do not do that and she goes in labor within next 24 hours,
yeah, then
there are chances that
cervical laceration and tears.
Lacerations.
Well, I think we are discussing a very important issue here, the pars speculum and par vaginal examination. As the faculties have opined, the pars speculum examination is very much okay. There was some question about the visibility of the knot. Well, they have seen it, so we have need to believe them. And the second thing, the need of parvaginal examination, I think there are reasons to do the parvaginal examination in this particular case, but this requires a lot of discretion and experience on the part of the obstetrician. It is the question that who is doing it, you know, because the obstetrician will only know, okay, in this case I should do the PV examination, and this case I shouldn't do. So that discretion will be there. But parvaginal examination cannot just outright deny that it is not needed. It may be needed. It is up to the case-to-case discussion.
Selection of
the
Yes, sir, that is there. What you wouldn't do for vaginal examination in every patient. You would do if you think that perhaps she is in labor, perhaps she has other conditions. And thirdly, the most important thing is that if you are not able to see the cervix with a speculum examination, then certainly you will do internal examination or vaginal examination. But as such, that's the way it has been taught to me.
No, the point, Kumar, that is that the point of merging of the Braxton Hicks contractions into the labor pain is absolutely not always certain every time. It can suddenly go into the labor pain, and I think Rujuta has correctly pointed out that suppose she goes into labor in next 24 hours, then you are really baffled of what to do. So I think a lot of discretion and experience goes into play while doing a vaginal digital examination here.
Yes. One more thing I want to add, sir, here.
Yes.
Two previous two previous spontaneous abortions and N-circle already done. And the students should know about the complications of continuation of pregnancy more than 37 weeks. Because many times they'll come with the labor pain and with in situ and cut through the cervical region. That is more common. Many times we observed. For that purpose, we have to use, prior to that, we have to use steroids and take out the stitches and allow her for a spontaneous onset of labor and delivery.
Yes, ma'am. Yes, sir.
We taught our students like this.
Yes, ma'am. So next.
Summary, Mrs. X, aged 26 years, gravida 4, para 1, abortion 2, and 1 live child.
Read out the full thing because you have already read it out. Let the faculty look at this and then they will comment. They will ask questions. Okay.
Okay. Okay, sir.
So what was your original question like when you said first?
Yes, sir.
You said you asked some question in the beginning and absolutely.
Yeah. So does it come under the definition of recurrent pregnancy loss? Having two second trimester abortions.
Yes, ma'am. According to ACOG, ISHRI, European Society and American Society, this patient comes under the secondary recurrent pregnancy loss. As recurrent pregnancy loss is defined by more than equal to 2 consecutive pregnancy loss by a clinical pregnancy loss. But according to RCOG, it is more than equal to 3 pregnancy loss. And in this patient, there were two second trimester, two conceived pregnancy and consecutive second trimester loss was found. With
So the definition of FOGSI applies to the first trimester abortions. More than 3 should be labeled as a recurrent pregnancy loss. But if the patient is having second trimester abortions, even one single abortion we can actually
we should start
advise
investigation.
for full workup, right? Full workup.
Yes,
even
we should start investigation.
Abortion is also equally important, and of course it's the discretion of the obstetricians who is treating the patient that will decide what should be, I mean, she should be labeled as a recurrent pregnancy loss or not. The only point is that if we consider 3 pregnancy loss and if we consider 2 pregnancy losses, then the number of the patients undergoing recurrent pregnancy loss actually doubles. And most of them, they are the sporadic cases. So that is why the criteria for 3 recurrent pregnancy losses came into existence. That is what I want to point out.
Yes.
So anyway, this is the discretion of the obstetricians, and this is being a second trimester pregnancy loss. We should take it seriously and investigate accordingly. So my point is, have we investigated her earlier, or we didn't get the time, or she didn't come to us for the investigations? Right?
No, ma'am. Patient should ideally be planned for thorough workup, which includes first is anatomical. First, we need to rule out anatomical cause when she would when she is non-pregnant. We should not look out for any congenital anomalies in the uterus as she has undergone second trimester loss. Then we should rule out the endocrine factors, which includes thyroid workup, then diabetes, PCOS, and excessive weight gain or the cause. Then the carrier, as they are second 2 losses with the carrier, as mentioned earlier, second karyotyping of the products of conception should be done to rule out for chromosomal abnormalities or any genetic deformities.
And what are the guidelines for the parental karyotyping? Is it routinely advised?
No, parental karyotyping, we usually, as recommended by ICOG and other guidelines, it should be karyotyping of product of concept test should be done. If it is euploid, then other causes of RPL should be ruled out. If it is aneuploidy, then aneuploidy is usually occurred in sporadic is a sporadic cause. That's why we need to do pre-implantation genetic testing and in the next time, and then we should
come to that specific investigation. I firstly want to know that a woman has come to you. She has had one miscarriage, and what are the additional things you would look for before doing investigating for RPL? Have you ever done in your clinical setting that the woman has had only one miscarriage and now you are jotting down the clinical points? When would you consider doing investigation just one miscarriage and other? What are these other factors?
Okay,
if come to PGM and all that, they are very important, but we will come to that later.
Okay, ma'am. If the age of the patient is more than 35 years, if a patient came with a complaint of infertility, if the first loss is in the second trimester of grossly normal looking fetus, then we should investigate in this case.
And
also, if patient has higher BMI, as in our patient, we should also look for thyroid. We should get TSH done and also check for diabetes.
And so many other factors also there.
Yes, so many other. History of congenital malformation, history of abnormality in the family.
Yes, ma'am.
So many other factors are there. The woman comes to you like hum apne kitab mein padhte hain that no, if the woman is only 30, I wouldn't investigate you. But sometimes we should be very specific, sit down, note her problems, note down the point in the clinical notes and see, no, I will do investigation in this woman, whether she is 30 or 29. Okay, that is important.
If there is a history of congenital anomaly or a history of mentally retarded child in the family, or there is a history of any inherited thrombophilias or any genetic abnormality running in the family.
Yes.
Yeah.
So, okay.
Yeah.
Hello. Yeah. Hello.
Yes.
By seeing your history presentations, already it's very clear that there are 2 mid-trimester abortions. So more suggestive of your cervical incompetency as a cause. So can you define this cervical incompetency definition? PG students, how do you define this cervical incompetency?
Cervical incompetency. It is cervical. It's also named as cervical insufficiency. It is diagnosed by more than equal to 2. It is sudden spontaneous mid-trimester dilatation of cervix leading to expulsion of the fetus.
Is it painful, painless? Painful or painless?
Painless. Sorry.
Should it be only one, or it should have a recurrent?
It can be only one, but indication of cerclage requires more than equal to 2, or it can be history based. Okay. Like for the definition of cervical insufficiency, it needs to be only 1.
Yes.
How will you diagnose cervical incompetence?
Cervical incompetency, there are 3 methods of diagnosis. First is history based, which is in our patient where more than equal to 2 second trimester sudden painless loss of fetus. Second is USG based diagnosis. That is history of either 1 preterm labor or history of second trimester abortion with cervical length at 11 to 13 weeks of scan is less than 2.5 centimeter or 25 mm. And third, when a patient is non-pregnant, if Hagar's dilator number 8 can be easily passed through the cervix, then it's also considered as cervical insufficiency.
I thought
are you still doing this Hagar number 8?
We don't do it anymore.
We don't
no,
do it now.
We don't do it.
We don't do it.
It's
but
a
to
pass.
diagnose. Yes.
Okay.
No,
Is
we don't
funneling
do
of
it now.
cervix important? Is funneling of cervix on ultrasonography is
Yes,
one
ma'am.
of
It
the
is
diagnostic?
important. Yeah, it's not a part of a diagnosis, but it is important. Like normally during the first and second trimester, cervix is T-shaped, then it converts to Y, then V, and then U-shaped cervix.
Which route of USG? Ultrasonography.
In transvaginal scan.
Transvaginal, yeah. So funneling of cervix should raise your suspicion, but it should not be a diagnostic factor. Right? You should not label the patient.
Yes, ma'am.
I think we will take circlage differently because that's a big issue and a very controversial, and it needs discussion also. But in the meantime, go back to the previous slide. Is everybody happy with the summary writing of this case? I think summary is the most important thing in any case presentation, because whenever the examiner asks you what is your case, they have to tell the examiner the summary. I think
I think there is no need to mention LMP-EDD again. She can just mention the period of gestation. And again, I think she was admitted on this date, etc. This is also not important. And
okay.
A small bit of just raising this point. The students just take care of this. That you have written on obstetrical examination, single live intrauterine fetus is fine with longitudinal lie. You read cephalic presentation. Do you need to write longitudinal lie when you write cephalic presentation?
Cephalic presentation, correct. And floating.
Is there any possibility that cephalic presentation will have a transverse lie? Okay, so that is one small correction, and I think
sorry, sir. Yes.
Part, I think a little bit of elaboration is necessary here because it's a case of recurrent early pregnancy loss. Okay, not in the detail of each pregnancy, but a short summary of like repeated order, twice consecutive mid-trimester spontaneous abortion, something like that. So that those wordings are important for creating impression in the examiner's mind. Also note that this is not the way you present in the examination. This is in your PG clinic we are doing. What will happen? All these things that you have written in your script will be taken away by the examiner. And they will ask you, isn't it? So you have to say it extempore from your memory. So summary is extremely important. And you write summary and commit to memory before presenting the case.
Yes.
Yes. Now, how we reach? Will now have you finished investigations, or you are?
No,
faculty members, please interact.
Yeah, what additional investigations you would like to do in this patient, even though it's clear that it's a second trimester abortion? What would you like to rule out?
Like in our patient, she came already with the cerclage at 36 weeks of pregnancy. So now,
can I add here something little bit, if you allow me?
Yes, yes.
Yeah.
Sir.
See, up till now, if you go to the next slide, where is the provisional diagnosis? Previous slide or next slide? Yes. See, now we have to have a final diagnosis in terms of, obviously, we're talking of recurrent pregnancy law, it comes in that definition, as you have discussed. But now we have to pinpoint also the cause. If we are able to arrive at a conclusion now from
Okay, sir.
this diagnosis that she is having two painless second trimester abortion, and most common etiology is incompetent os,
Yes, sir.
incompetent cervix, and in this patient also a stitch has been put. So now we know it is a incompetent cervix, and now main query is, now I think we should not we have only half an hour left to complete the discussion. We should be more focusing on the management of the patient or management of a pregnancy with the cervical incompetence where the stitch is there. So
Yes, sir.
we should focus on that now, because if we go into the RPL causes and investigation to look for RPL, I think we will deviate from our case.
Yes, sir.
So we now please focus on that, and in the exam, obviously the student should really focus on and pinpoint the diagnosis also if they can from the history taking and on the examination. So in this case, this is the case where we can pinpoint the diagnosis that it is a case of incompetent cervix.
Yes,
So,
sir.
so now you tell that now the patient is at 36 weeks. How will you proceed now, or what investigation, extra investigation you want to have here before you want to go ahead?
Yeah,
Or
that,
the other question one can ask is that in pregnancy, suppose she has come earlier also, how will
Yes,
you what else you will see on ultrasonography when you do ultrasound of a patient with cervical stitch in situ? So these are the few important things you should know in this case.
Okay, sir. In this patient, first we will do the routine investigation and look out for blood group CBC, a complete blood count including hemoglobin, platelet, and total count. Then we'll look for any local infections. By WBC, we will come out to total count. We'll look out for any infections in the body, especially when cervical sarclage in situ. There are chances of vaginal bleeding or vaginal infections. So to rule out that, we will do vaginal swab and urine culture sensitivity to look out for that. In USG, we'll look for the baby maturity and lie of the baby, and look at the position of the placenta, which was already confirmed by earlier scan as posterior, and in this spring, and then in our USG also it turned out to be posterior. And we'll confirm the Leica and Doppler of the baby, and decide for the management based on that. If everything is not turns out to be normal, we'll plan for removal of stitch and withdraw the progesterone support, as she
Vatika,
already.
wait. Vatika,
Yes,
yeah. So your patient has had a cervical encerclage at 12 weeks, right?
Yes, sir.
So what kind of sarclage was? Is it a history based, examination based, ultrasound based? And why this encerclage was done at 12 weeks? Why do you do encerclage at 12 to 14 weeks? Can you answer that?
Sir, in my patient, the cerclage was done in view of history of two painless second trimester loss. Sir. So it's a history-based cerclage.
Okay,
and this was done at 12 to 14 weeks, as the cervical length, which we determined in these cases on USG TVS, is done around 16 to 20 weeks.
Why did we do it 14 weeks usually? Why do we do it 14 weeks? Why? Any reasons?
Because of previous second trimester loss, we do not wait for it to reoccur. Especially in this, and our patients have the histories of
we could have done it. We could have done it in the earlier gestation also, no? Why at around 14 weeks?
I will wait up to 12 to 14 weeks.
Yeah, why do you wait to
In our patient, anti-scan was not done, but ideally anti-scan should be performed at 11 to 13 weeks. So we confirm the gross, like there is no gross lethal congenital anomaly to the baby. And after that, we generally do. But in this patient, as she had private visit, anti-scan was not done.
Yeah, invariably nowadays ultrasonography are good, and they can gross malformations usually nowadays are seen. and whatever genetic problems, whatever it there, they will go undergo abortion at before the 12 weeks itself. So
Yes.
so we pick up. So whatever comes in 14 weeks, we decide that.
Yeah, that's
Yes.
right. Mhm.
Then in case this, how do you follow up such patients if you are not putting an answer clutch with your ultrasound? How do you do the follow-up management? If you're not putting an answer clutch?
Yes, sir. We will start if the patient don't have such history and just a history of second trimester, or there is an incidental finding of cervical length to be less than if there is an incidental finding of cervical length to be less than 25 mm, we just have to start her on the progesterone support. If the cervical length, if there is a history of preterm labor and cervical length turns out to be less than 30 mm but more than 25 mm, then we have to do the TVS screening of cervical length every 2 weekly.
Okay.
Until we can do cerclage till 24 weeks. So if it is less than 25 mm with history of loss, we need to do the cerclage.
What is therapeutic and cerclage? What is diagnostic? Means prophylactic as well as therapeutic. Two options are there. No?
Yes, therapeutics.
Therapeutic
Yes.
is go for prophylactic.
Yes, therapeutic cerclage. It's also called as physical examination based cerclage, in which the patient came with a preterm labor pain before 24 weeks of pregnancy and her cervical dilatation is less than equal to 2 centimeter and without a rupture of membranes with or without a bulging of membranes. In that patient, we need to do emergency or rescue cerclage to prevent pregnancy loss. It has bad prognosis and prophylactic antibiotics should be given. If there is a bulging membrane, then we need to reposit the membrane by stiff Trendelenburg position or using a moist swab by gently placing it in the cervix and pushing the membrane above, making sure membranes doesn't rupture, or retrograde filling of bladder by 500 to 600 ml. Normal saline or small Foley's catheter can be placed in the cervical os and inflated it to 10 to 20 ml, and after that cervical cerclage need to be done. The difference between both the cerclages, in this emergency cerclage we do the cerclage in a from 12 o'clock to 6 o'clock position, and the other cerclage need to be placed from 3 o'clock to 9 o'clock position. While in the prophylactic cerclage, which is the McDonald or Shirodkar, in that we do purse string sutures. It is done based on the indication as discussed earlier, and in that we pass the needle from 2 o'clock to 10 o'clock, then 8 o'clock and 4 o'clock position.
Which condition you're going to put for a prophylactic? Some conditions, no?
When cervical in prophylactic cerclage, history of it is history based where there is more than equal to 2 earlier second trimester pregnancy loss, as in our case. Then second is if there is history of 1 preterm labor or 1 second trimester loss, along with which the length of the cervix should be length of the cervix is less than 25 mm. Then we do or there is history of preterm labor, or again there is a history of cervical cerclage in previous pregnancy. In all these cases, we go for prophylactic cerclage.
What about twin pregnancy, multiple pregnancy? Do you heard?
They are under investigation whether to do it or not yet. It is still under trial.
Yes.
Okay, nice. So we have finished now. Let us come to the point, and now only 10 minutes, 15 minutes are left. So now go to the management issues. Now you know that she's carrying.
I have one question, sir. What is the evidence behind progesterone? You mentioned that you will give PGN. What is the evidence behind that, and which trials were done? Because it is very important, because lots of PGN we prescribe in our country, and that is leading to obstetric cholestasis.
Yeah.
Yes, ma'am. Progesterone,
progesterone is given as it helps to maintain, it helps to reduce the uterine contraction. It also has immunomodulatory support, and it is but also helps with the implantation. But when in this case we started after the circulars, and ma'am, the trial that was done for progesterone was on promise trial, ma'am.
Only promise?
Not promise.
Prism and promise.
Prism trial, ma'am. Prism and promise trial.
What did they say and which progesterone you prefer? There are two types of currently progesterone being used. Which one would you prefer? And what did
micronized
progesterone
and the vaginal preparations are preferred over oral, as it has local implication. So vaginal micronized progesterone is preferred.
Really?
Yeah, because it escapes the enterohepatic circulation, right? Because it escapes the
Women do not like vaginal in Uttar Pradesh. Okay.
So 400 micrograms of natural micronized progesterone.
So you are in favor of continuing progesterone how long in this case?
In this case, we will
the circlage is in C2. We will continue in this case. After removing the circlage, we'll discontinue the progesterone support and also cover the patient, give a steroid cover, and allow the patient to go into spontaneous class.
You have done circlage.
Up to 36 weeks, you have to give progesterone.
Yes, yes.
You have to see while giving antenatal steroids whether if she has crossed 36 or 37 weeks, then there is no need to give. You can you up to 36 plus 6 weeks of gestation, right?
Yes, ma'am.
Corticosteroids, right?
Yes, ma'am.
What gestation would you use corticosteroids?
And ideally, this should be removed.
Between
36
to 36
weeks.
Between 36 to 37 weeks, or at any time if a patient has undergone dilatation more than 4 centimeter, or like in preterm labor, or there is rupture of membrane or signs of chorioamnitis are present.
You are saying you will remove stitches at 37 weeks?
You are not going to wait till 4 centimeter dilatation. When?
No, in preterm labor. Sorry, ma'am. That is when we don't
Those
do
are
it, sir.
contraindications. Contraindications.
Yes, yes.
नहीं आप बताओ ना steroid कब दोगे? That's a question. I got carried away by your lots of answers.
No.
Well, steroid coverage should be done between 28 to 32 weeks. But if the patient doesn't take regular antenatal visits, then we can give it till 36 weeks of maturity.
आपका दोनों आंसर गलत है. पिछली बार आपने 37 कहा, अभी भी जो कहा गलत है. पढ़ लीजिएगा, प्रॉपर गाइडेंस है इसका. No, it is not 37 weeks. Certainly not. And how many times would you repeat steroid? कितनी बार देंगे? कितनी दफा?
For like betamethasone should be given at
भारत में नहीं है. बीटा भारत में नहीं है.
नहीं है. So you have to repeat it twice, right? But the interval should be more than 7 days.
7 days.
Yes, ma'am.
But we have done one study, madam. It is up to 36 weeks. Corticosteroid. I mean, international study. 36 One was for
corticosteroids in this case. That is my question.
Why? She's 36.
Patient was not given steroid coverage in the private, and she came to us at 36 weeks, 4 weeks pregnancy, and her maturity was confirmed by the USG scan.
But why steroid at 36 weeks?
Yes.
We haven't given, ma'am. We haven't given, and steroid coverage was not even done in the private before 36 weeks also.
Okay. So now what do you do next? You know that the stitch is there. You haven't given progesterone. The patient is not complaining of pain. You have kept her admitted. Okay. Now what next?
The
question is whether you should remove the stitch instantly or you should wait for the onset of labor signs or something like that. Do not go for cervical dilatation.
No, ma'am. No, sir. Sorry. Patient, as she already crossed 36 weeks, we should plan for removal of the stitch and progesterone support should be stopped. And because we don't know whether patient will be compliant for further monitoring or not, and if the patient goes in labor at home, that will be a traumatic delivery. So it would be preferred, as she's 36 weeks, 4 days already, then cervical stitch was removed in our patient and progesterone support was stopped. And she was monitored for 24 hours for any complaints and was allowed to go into spontaneous onset of labor. And we asked her to follow up after 3 days.
That means you discharge her home.
Discharge her. और
तुम आने को कहोगे और रास्ते में बच्चा हो जाएगा सड़क पे।
we observe.
नहीं कर सकते बाबा, बहुत डेंजरस
Then
है।
why is it?
No, she's admitted.
No, keep her admitted.
Sorry, ma'am.
Till she delivers, you have to keep her admitted.
Okay,
It's
okay.
a high-risk case.
Okay, sorry, ma'am.
This is a precious pregnancy for her.
That
You can admit it, okay? Because normally the guidelines which we read are RCOG or ACOG guidelines, and we cannot afford to have such kind of management that they have in their country. So it's better that patient is there with you, right?
Yes, sorry. Yes, ma'am.
RCOG का
I just want to clear one thing. From 22 weeks to 23 plus 6 weeks, you should discuss with the patient, right? Because
Yes.
many times, less than 24 weeks babies, they are surviving. From 24 to 33 plus 6, you should give steroids to the patient, right? In case of if you suspect preterm labor. And from 34 to 35 plus 6 weeks, you should use your discretion whether it is clinically indicated, right? So
Yes.
this is the final, I think, regarding the corticosteroids.
Why we are worried about steroid, Vartika? हम क्यों नहीं जैसे अंधाधुंध सब दवाई एंटीबायोटिक देते हैं, एस्पिरिन देते हैं, डेक्लोव देते हैं, इसके बारे में हम लोग चिंतित क्यों हैं? Why we are worried about steroid to our women or children? Why?
What is it causing? What is it causing to the baby?
Yes, that's the right question. What harm it is doing?
Ma'am, it is a steroid, ma'am. It can cause flaring up if the patient has chorioamnitis. It can flare it up. And
तो यूजुअली तो हम लोग कोरियो में कुछ खास इंटरेस्टेड नहीं रहते हैं। आप नॉर्मल में बताइए, normally pregnant women में बताइए।
It can cause transient hyperglycemia, and also it is a immunosuppressant, so that might increase the risk of infection in the mother. And
it will cause transient hyperglycemia if the woman is GDM or diabetic. It will not cause in normal person.
No.
It will not
Yes.
cause immunosuppression with a dosage of 6 milligram 6 hourly, a total 24 milligram of Dexa. It will not cause. As again in Uttar Pradesh में beta नहीं मिलता है. I'm not sure about other parts of country.
Hey, Uma, the message is that the betamethasone is available, but not the proper salt.
Correct. Correct. That's the right one.
Government recommendation is on dexamethasone, and all our students may say that dexamethasone is the officially approved by the government of India.
Yes,
Okay?
sir. That is the right
Yes,
answer.
yes, right.
And
Yes,
we have to think about Vatika, we have to think about what are the benefits of giving steroids to a baby, premature babies. How it will help.
sorry, ma'am, can you repeat the question?
No. How it will help? What are the benefits of corticosteroid prior to 36 weeks? Perinatal.
It acts on the type 2 pneumocytes of this baby, and it increases the production of phosphatidylcholine surfactant, and it helps with the production of surfactants, thus resulting in early maturation of lung.
That is the more benefit of giving steroids.
Okay, so now what next? You have given, you haven't stopped this thing, progesterone. You haven't given the other, and the stitches you have removed. You have kept her admitted. Now, how to follow up this patient? I mean, management. She has gone into spontaneous labor, as you said. How do you manage labor in this case?
We should, as the patient has previous home delivery, so that's why there may be chance that she had during that delivery she might have gone under she might have cervical tear which wasn't diagnosed, as she has not taken any postnatal visit after that delivery. So in this patient we need to carefully see the progress of the labor, and look for and especially during the second stage of labor we need to take care for the for the traumatic deliveries, or look out for cervical tears and other. But otherwise, a patient can be allowed to go into spontaneous labor, and if needed, we need to augment.
How will you augment? What is the difference between induction and augmentation? How will you augment this woman?
Induction of labor is when a patient, if in this patient, if she doesn't go into spontaneous onset of labor even after 40 weeks, or there are some USG changes, then we need to induce the patient. By induction, we patient is not in labor and we are inducing the patient to go into the labor. And in augmentation, patient is already
you got my point. You answered correctly. Why would you continue this pregnancy till 40 weeks? Would you? Continue this pregnancy till 40 weeks?
But
ma'am,
there is no other obstetric indication to terminate it before.
I don't
40
use word terminate. I use the word deliver.
Okay,
Don't you think having lost 2 pregnancies in second trimester is an obstetric indication? As far as I'm concerned, it is.
Ma'am, we
don't have the investigations even. You don't know LA, ACLA, you don't know so many things, thyroid, PCOD, GDM, so many investigations we don't know. So she's 36 weeks and we have continued for another month, 40 weeks. You have no Doppler? I think you have Doppler, which was normal.
Yes, Doppler, Liker and Doppler were normal. And if there are any like,
and she's not diabetic, right? She's not diabetic. You have evaluated her, so you know she is a low risk patient. So what is your stand here? Would you actually induce her at 37 weeks, or would you continue till 38, 39, 40? Will you wait for spontaneous labor? What is your take?
Only my concern will be, as the pregnancy advances, weight of the baby might increase, and it might increase the chances of instrumental.
It is below average. Right now it is 2.5,
yes,
right?
Ma'am, it's below average.
Yeah. So how much baby weight you expect the baby to gain weight in the last 4 weeks?
Unless she's GDM or diabetic, there is not much of chance that she will grow dramatically over these last 2-3 weeks. So I think that the chance, the possibility of a large overweight baby is unfounded here. So I think now you can go ahead with the plan of management, whatever you are saying. You go ahead.
In last 4 weeks, there will be 150 to 200 gram per week.
150 to 200
weight gain will be
in fetal.
Okay.
I asked you how will you manage. Sir asked you how to manage.
We are just interested whether you will give whether you will do induction of labor or will you wait for spontaneous labor, and what are the actually but benefits and like advantages and disadvantages of each method. If you induce her at 37 weeks, what are the chances that she'll actually land up in a cesarean section because of the induction, or spontaneous delivery versus spontaneous delivery at whenever she will go in labor up to 40 weeks?
If there are no obstetric indication for induction of labor, we will allow to go in the spontaneous labor onset of labor. And problems with the induction of labor will be that as we are inducing the labor, there might be chances that there is failure of induction of labor, or there is fetal distress, or increased chances of operative or interventional deliveries. And
so in the examination, you are supposed to say whatever is ideal on the books, right? In the practice, you may actually have some variation in the management, depending on or at the discretion of the clinician.
Based on bad obstetric history, we may induce the patient.
It should be by book.
Yes.
This is what I think. I don't know the other faculties. Actually, they may.
I would also like to discuss with the parents. उनके mother, father का क्या चाहिए उन्हें, because ultimately हम लोग baby को deliver कर रहे हैं parents के लिए, mother book के लिए नहीं. अगर वो चाहते हैं कि नहीं, this is what I want, I would go by them. Because
the choice will be given to the patient. Right?
That is what I'm saying. You got to talk to the woman. You got to talk to the father and explain the consequences of performing vaginal or cesarean or whatever. दोनों का अपना अपना खतरा है. समझाएं.
I think that to cut this long discussion short, our time is limited. Now we are going to finish in 3 minutes now. Tell us the indications of cesarean section from your end. Forget about the cesarean section, maternal request or something like that. You tell us what are the indications from obstetrician point of view. What are the indications of C-section in this case, and whether you will keep the stitch there or not in that case.
You could keep.
In this patient, based on bad obstetric history, we can go for induction of labor, or in the USG, if it is found to be severe oligo, or there are Doppler changes in the USG, we can go for that. And in the cervical stitch, when we take it on the table after giving spinal anesthesia we remove the cervical stitch.
No, sir
Yeah,
didn't ask
can
you
you
the
tell me
question.
one
Sir
condition?
asked you, if you are doing cesarean, would you leave the cervical stitch there or not? That was the question, what he wanted to.
No, we will, while doing this ES, we will remove the stitch from pervaginal.
No, if she wants another baby, you can leave the stitches there and then till she becomes pregnant. You can do that actually.
Okay.
Yeah, that's what sir asked you. Okay, other indications of
In
cesarean.
abdominal cerclage, we do it that way only. Yes, ma'am.
Yes, ma'am, definitely. Sir, और पूछे कि और क्या indication है बताएं नहीं?
Can I ask one condition? Can I ask one question?
Yeah, sure.
In which condition or in which cervical encerclage you will have to do cesarean section?
Ma'am, in
Just
abdominal,
because you are not able to deliver the
abdominal
patient
cerclage.
vaginally.
That's correct.
Yes. Because at that time you're not able to remove the stitch vaginally, so you have to proceed with the.
And in that case, we need every time we need to go for cesarean section, and that stitch
Cesarean
need to be
section,
removed
you
only
have to
after the completion of the family.
Yes.
Yes, ma'am.
So there
How
was
do you,
at one
yeah.
point, there was at one point a concern raised about this growth restriction, FGR.
Yes, sir.
Now, would you like to follow this up with any investigations, or you're by now convinced that it is not a case of FGR, and you will take the decision according to the normal AGA baby?
For FGR, as we will monitor the vitals of the patient, whether we will try to find out the cause of the FGR, which in most common includes the gestational hypertension or preeclampsia. We will in that case we will look out for the signs, whether the patient is having any headache, blurring of vision, vomiting, or severe epigastric pain. Then in the vitals of the patient, we'll look out for whether there is edema or not, and we'll monitor her BP every 4 hourly or 6 hourly, depending whether it is raised or not. And in investigation, we will look out for CBC, in which platelet count are important in severe preeclampsia. Then hematocrit is important. Then we'll look out for renal and liver function test. Then proteinuria in urine RF. We will try to rule out preeclampsia by all these measures.
Okay, so all these investigations are normal. So we have ruled out almost with FGR. So now this case, and I would like to close the discussion. Any last final comments from the faculty, and we'll close it.
Yeah, I want to ask to these students. Am I audible? Yeah.
Yes, sir.
Okay, yeah. So now this patient has delivered normal, vaginal delivery. So these two students, how do you advise for her next pregnancy? There are two groups now. Some ladies can, after you remove the stitch, they can deliver very soon, maybe in a day or two, or in a week.
Yes.
And some ladies, still after removal of stitch, they go till 40 weeks, sometimes 39 to 40 weeks. They go beyond 2 weeks, 3 weeks, like that sometimes. So obviously you'll be inducing still. So how do you advise according to that? Do you have any advice according to the time of delivery in the next pregnancy?
In the first patient, where after the removal of cerclage, the baby was delivered in 2 days, we need to do a prophylactic cerclage at 11 to 13 weeks in the next pregnancy. But in the second patient, where she was continued term and didn't go into labor, there we can do serial USG monitoring from 11 to 12 weeks and look out for the cervical length. If it is less than 25 mm, then we need to go for cerclage.
Okay, good.
Okay, thank you very much.
So, congratulations, Dr. Vartika, Shivakini. Very well read topic. Both of you have done a nice job.
So, thank all the faculty.
Can I just one thing? Do you know any new method? Do you know any new method to detect the cervical incompetence? See, we are talking about length, but is there any new technique to know that the cervix is incompetent?
Funneling of the cervix can be
funneling T, U, V, all that we know.
Okay.
Cup 6.
And last question.
Some to know the elasticity of the cervix.
Sorry, ma'am.
Yeah,
Know the
some
elasticity
one
of the
special
cervix.
ultrasound. Okay,
Something to do with,
elastogram.
yeah.
Okay.
We will know the elasticity and
okay, that gives the color coding. You know, you get purple, orange, and depending on that, you can know whether this cervix can withstand this pregnancy. So that is one new technique. If the facilities are there and if the patient has bad obstetric history repeatedly, you can get that done.
Thank you.
Okay.
Thank you, Sheila Madam, for
Just one point I would like to say that husband was nowhere involved.
Yeah.
The baby of both.
The next pregnancy, he will be involved. Thank you, Sheila Madam. We have comment, but another word of caution for the students also that those so-called T-shaped, U-shaped, V-shaped bear no significance in the causation of the subsequent pregnancy loss. This information is very important. And
yes, sir. We need to be alarmed by that finding, Judge.
Yeah. So I think that with that note, I will complete this case presentation.
Thank you, sir.
All the faculties, Dr. Shailaja, Dr. Shailaja Arbidri, Dr. Uma Pandey, Dr. Rujuta Fuke, and Dr. Gotet Doke. Thank you so much.
Yeah, thank you, everyone. Yeah, it was nice
Thank
meeting
you so
all
much,
of you.
Ashish sir, Sheila
Thank you,
ma'am.
Hafiz
Thank you
ma'am.
so much.
Hafiz, thank you so much.
Yeah, thank
Very
you so
nice
much.
discussion. Yeah, good.
Thank you so much.
Rangini.
Yeah, ma'am. Sheila ma'am. Sheila ma'am, anything, the final comments? Sheila ma'am.
I think it went on well. Every faculty was involved and everybody had asked their questions accordingly. So good job done by all. Thank you.
Thank you so much, sir. I would like to have the quick on the performance of the students because I think they have done well, but still I would like to have just quick one or two words from each of the faculties because that will give them the encouragement, no?
Yeah, so I have already told that they have read the topic very well in depth. They have gone through all the guidelines. They actually the concepts were clear. Some one or two points that they were lacking, we have already pointed out that.
Dr. Shailaja, madam.
They have done very well, sir. They did also and answered also well. And they need to know about what are the other immunological causes and genetic causes, when to do fertilizer, all these things, indications and all they have to.
Yeah, thank you. Dr. Uma, ma'am.
I would like to say they are here, so I cannot take their names, but they were brilliant, absolutely brilliant.
Shivangi and Bhattika is there, madam.
Yeah, but
Thank
I
you,
cannot
Dr.
say now in front of them that who was good, who was not. I don't want
Okay,
to.
ma'am. You just Dr. Doke. Fine.
Yeah, these two students are good and they are well read. And but definitely they are in final year. So I request Dr. Gandhi sir to give them a chance of surgery for all these encircular surgeries. if you get a chance, give them.
Good one, good one.
Ashish sir, final words. Ashish sir.
No, I must thank each and every one. The students have done exceptionally well. So I request the examiners to kindly pass them with more than 60%.
One point I would like to point out here. So can I?
The husband will be definitely involved. That is.
Thank you so much, sir, Ashish sir. So I'd like to thank you, the students, Dr. Shivangini Mehta and Dr. Vartika Kumari. And most importantly, they are a very enthusiastic guide and professor and head, Dr. Mayur Gandhi, for guiding them as well as bringing them at this front for such a challenging topic. And for my assessment, they have done really well. It's a very challenging case actually, and which is in the practical situation as well as in the examinations. And more of it, like I'd like to thank you all of our faculty, Dr. Ashish Kumar sir, Dr. Shailaja, Dr. Uma, Dr. Rujuta, and Dr. Gota Doke for taking the discussion to the next level. As we constantly are saying, would like to take much better in the next post-graduation program. So I'd like to thank you them all. And would like to move on to our next session, that is session 3. We have another teacher par excellence is waiting in line, Professor Arup Kumar Majhi sir. So this is the session we have introduced from this session. After that, we got many requests from the students that they would like to have, because many of the time the students remain confused or they are having difficulty how to start a specimen in examination. We got requests from many students. So then we, after having the approval from all our the senior the Sheila Mane Madam, Dr. Ashok Kumar sir, Ashish sir, then we have this session, that is tackling gynecology specimen. So for this, the first session starting from today we'll have Dr. Arup Kumar Maji. Sir is professor at Santiniketan Medical College, Bolpur. Over to you, Arup Kumar Maji, sir.
Arupda, can you hear us? Dr. Arup Maji?
Maji sir, are you there? Sir was there.
Professor Arup Kumar Maji, please unmute yourself. Yes.
Am I audible?
Yes, sir. Yes, sir. Please go ahead.
So should I start now?
Yeah.
Yes, sir. Over to you, sir.
Your name has already been. Yes.
Actually, there are some interruption. A very good afternoon, everybody. Thank you for adding. This is a very important and inevitable topic in exam. And actually, the introduction of the specimen. Today we are starting with the gynecology specimen, particularly the fibroid and cervical fibroid and ball ligament fibroid. And the questions on the specimen is endless, and mainly depends also on the wish of the examiner, who is the examiner, who likes the which part. And there are so many areas. So, but there are some basic things. If you go to that basic thing of the specimen, they will be able to answer all the questions. I am now sharing the slide because now sharing the slide. This is, you see, some specimen I will show and see. Is it visible, Ashish?
Yes, visible. Make it full screen, please. Yeah.
Okay.
Done.
Now full screen. And you see, this is any basic questions for any specimen will be like this. You first describe the specimen and then identify and what is your diagnosis, what surgery has been done for this particular specimen, and examiner will ask you what are the presentation of the case. That is the build up the case, the patient's profile, symptoms, sign, and examination finding. And finally, how to reach the final diagnosis in these cases, and what may be the alternative management of this case according to situation. But all of us, the students, please concentrate on the specimen that related to that specimen, because not so widely the pathology and covering all the aspects. But you always stick to the specimen. When the examiner will ask you, go to the. Now this, you see this specimen. Now first question is to describe the specimen. How do you describe the specimen? The specimen will be described like that. There will be different languages. This is the mounted specimen of uterus to cut open to show the uterine cavity within which there is a small growth. Then naturally, the question is, what is the diagnosis? The diagnosis is, the common diagnosis is the fibroid, that is a submucous fibroid. It's a small size of the submucous fibroid. Then the question, you come to that question, and what surgery has been done? You can see what surgery has been done. So when a specimen is given, always you examine the specimen, observe the specimen and examine the specimen, and very gently and politely you see all the surfaces. The surface in front of you, lateral surface, and the posterior surface. What surgery has been done? If you want to answer this question, whether all the anatomical structures are present or not, like this, whether the tubes and ovaries are present here, and whether the cervix is present here. So you also see the backside, that's the backside of the specimen, and whether the tubes or ovaries are present. In a mounted specimen, it is usual that the tubes and ovaries is compressed. So examine very meticulously whether the tubes and ovary or not, or one-sided tubes or not. So this specimen apparently shows that only the uterus body and cervix has been removed, and there is no tubes and ovaries, and it is better visible by the posterior surface. So what operation has been done is the total hysterectomy. The operation has been done is the total hysterectomy. If there is a lack of cervix, that should be the supracervical or subtotal hysterectomy. Then next question is build up the case. That is the clinical. What is the clinical scenario with patient? Clinical scenario means you will have to say what is the age of the patient, approximate age of the patient, what is the parity status, and what are the symptoms, and what examination finding, and later on how will you definite diagnosis. So this patient, as there is a submucous polyp, the commonest presentation of the uterine fibroid, all of we know, the AUB, that is AUBL, abnormal uterine bleeding. But what for? Usually the heavy menstrual bleeding. But this particularly patient, you will have to say, as there is a submucous fibroid, so it is there also the intermenstrual bleeding or continuous bleeding. That is, always it is said, the fibroid, any fibroid arises intramural, then either comes inside or outside. So primarily there may be the menorrhagia, that is the hemimenstrual bleeding, but this was a must. This is the case of there is the intermenstrual bleeding or non-cyclical bleeding. And another thing is, as there is a submucous fibroid, the pain is common in this one because uterus always try to expel the submucous, that is the fibroid. And another is if there is a degeneration, the patient may complain also that is the white discharge. And what are the other, not related to this, what are the other symptoms in this case? In any fibroid case, there is the pelvic pressure, that the pressure symptom, that may be the pressure symptom, and back pain like that. Sometimes dysmenorrhea, and dysmenorrhea unlikely in absence of the other physiology. But you don't say by mistake the patient has the infertility, because the infertility, if the patient had infertility, there is hysterectomy could not be done. So this is the common mistake of the student. When he see the specimen, he always remember the book and says these are the pain and abnormal bleeding and the infertility. Don't say by mistake. And if by mistake you say the infertility, then the question will come: what are the causes of the infertility in case of fibroid uterus? Only in case of fibroid uterus, not more than the 5% cases are the infertility. And for that management of the myomectomy, to treat the infertility, definitely exclude the other causes. So that is one important thing. Next is the patient's examination finding. And in this case, examination is that only the pallor, what are the pallor, we will say, and also corroborate with the laboratory report, hemoglobin. And per abdomen, this specimen, there will be not palpable. It is not more than the 12-week size. So per abdomen is not palpable. And by doing PV examination, the uterus is enlarged, uniformly enlarged, and the fornices are clear. And next question is how to reach the final diagnosis. Definitely the investigations of the case of, that is a case of that the ultrasonography, and next you can do the MRI. The ultrasonography is sufficient. I think ultrasonography is sufficient for the diagnosis of the cases. And MRI is usually reserved for the cases for proper mapping. Now the MUSA, that is the ultrasonography, can do the morphological assessment of the location and size and of the proper location of the fibroid. It is the MUSA. And the MRI can also can do very well, better than ultrasonography, definitely. But in these cases, other investigations you can be do the hysteroscopy, and also the sonosalpingography, the ultrasound sonosalpingography, it can be diagnosed. So you say always in this case the sonosalpingography and hysteroscopy you can do, but if we do the hysteroscope, preparative diagnosis is the submucous plan for the hysteroscopic resection, and then the laparoscopy is usually associated pathology and more. So these are usually the investigations of these cases, and investigations always the details may be asked regarding the investigation. And what will be the management of this case? You have done in this case in the total hysterectomy. Total hysterectomy, that the removal of the uterus with the cervix. So what alternate management could be done? Suppose the patient is very younger and the paras, nulliparous, or one child, see one side. What surgery will do in this case? Definitely in this case, appropriate is the myomectomy. Myomectomy in all cases of fibroid, the surgical management is the myomectomy or hysterectomy. And myomectomy when the patient is younger, particularly less than 45 years, and there is a patient needs also the child, myomectomy is done, and the perimenopausal or postmenopausal, the hysterectomy is done. And this is the ideal case of the hysteroscopic myomectomy. In here, the examiner will ask what are the types of the fibroid that can be hysterectomy, myomectomy now. Now, standard answer is the type FIGO answer. There is the FIGO. Up to the know, all of you know the 9 of which the 0, 1, 2, 3, 4, 7 is up to the uterine fibroid, and 8 is the other than the uterus, and 9 is the hybrid fibroid. So, in case of this case, only the 0 to 1 type can be done by the hysteroscopic removal, and they deviate if the patient, the examiner is more interested on the hysteroscopy, what fluid you will, what is normal saline, what will the glycine will use. Monopolar, if you use the monopolar pottery, you don't use the normal saline. So this interested examiner can ask you the hysteroscopy. So 0 or 1. But what's about the 2? 2, if the 2 is the size is less, 2 means the more than 50% inside intramural. But if the size is less, that is the 3-4 centimeter, that can be done. That depends on the surgeon's expertness, and surgeon will decide. But 0-1 is the subtotal, that is the hysteroscopic myomectomy can be done. So this is actually about the surgery. Other surgery is in the case of in other position. Suppose there is a fibroid, multiple fibroid. I'll go to show the cases also. Multiple fibroid, you can do the myomectomy, or the multiple fibroid or single fibroid, perimenopausal, postmenopausal, you do the hysterectomy. So what are the other management? That is the management in case of fibroid. You maybe face that question. First is expected management. Why expected management? The majority of the uterine fibroid is asymptomatic. And of them, the commonest symptom is the abnormal uterine bleeding, abdominal metabolism. Either heavy menstrual bleeding or intermenstrual visit in this type of fibroid. If there is a patient of the symptomatic, and then you start the management. What management? And the medical management and surgical management and radiological management. 3 types of management. Medical management, I just taught the outline in this sort of time. Now the medical management is you do first. You always says the iron you will have to give the patient suffer from, and also that is non-steroid anti-inflammatory drug. They usually reduces the pain and not so much extent of the bleeding. And the tenexamic acid definitely reduces the this is the pain. But other drugs, this is the antifibrinolytic tenexamic acid. You can give also the mefenic acid. But other drugs like the SPRM, that is the ulipristal, uh, now is the mifepristone are used. And what is the present status of the ulipristal? Ulipristal was used one time extensively, but due to the subabnormal effect of the endometrium and also the hepatotoxicity, it was banned in many places. But what is the standard recommendation now is that you do before giving the ulipristal, always you do that is the liver function test, and you can give 3 months, and after 1 month again liver function test, and you can give 4 phases. The 2 months, 2 months gap you can give 4 phases, but always before and after starting, and at the end of the year you always see the that is the liver function test you will do, because it is said that is proof that it is a hepatotraction and 5 milligram once daily. But it is claimed that ulipristal not only the reduces the blood abnormal uterine bleeding, but also the size to extent. Mifepristone also acts in the same way, but there is debatable whether it reduces the side effect. 5 to 10 milligram in many places the not available in the dose 25 milligram is given. And recently the other drug that is the GnRH, all of you know, not more than 6 months, but is a temporary regression, again fear of the loss of the bone density and postmenopausal syndrome. And GnRH antagonist also used, and recently the combination of the relevolics and estrogen and progesterone available, and it is said that after you can give up to 12 months. And it is said that BMD, in fact, BMD becomes intact, and AUB is definitely reduced. Another radiological is the uterine artery embolization. The family, what the family not completed, you cannot do it. I am not going into detail. And other is the HIPU. HIPU means that that is different types of HIPU. All of you know high intensity ultrasonography, focused ultrasonography, high intensity. That may be sonography capture or the MRI by the MRI approach. But it is not so popular, but it is also a non-invasive technique, and 3 to 4 hours, matter of 3 to 4 hours, and patient can return home. It's a very effective, but problem is that you also must consider your fertility status, because after HIPO there may be fertility may be altered, and there may be decrease of the fertility. So these are the gross Now I come to the specimen, as time is short. This is the submucous fibroid. You see this specimen. You see this specimen. This is the intramural fundal fibroid. And when you see this specimen, you also see the what operation has been done to see the other surface of the specimen. You see already that is the tube and ovary are compressed. So you will have to observe it very meticulously, and definitely the operation has been done. The total hysterectomy and bilateral salpingectomy question is like the first symptom. Next, you see, so when a specimen is given, it is a very common question, but very easy question for the undergraduate actually. How to identify the anterior surface and posterior surface? Posterior surface, you can see from anterior to posterior round ligament anteriorly, middle is the fallopian tube, and is the ovary and ovary. This is a very simple question. And also there is the extension of the peritoneum in the pouch of Douglas. But anteriorly there is the deficiency of the peritoneum in the lower part due to the attachment of the bladder. This is a simple question, but you always be ready for that. And this case you see one important finding here is that this is the fibroid, the enlarged fibroid, irregular fibroid. Definitely there are possibility of multiple fibroid. And here the tubes and ovary are visible, and also see the parasource. Sometimes examiner may ask, how to identify cervix? Cervix is identified seeing the external loss, and also external loss. By seeing the external loss, you can diagnose is the peras or nulliperas. Because of nulliperas, it is almost pinhole and circular. But here you can see, and here is the transverse. As the hysterectomy is definitely done, definitely it is a pirasomen. But that I am showing you for to see the cervical condition. Now, this is the case, and you can see the uniformly already uterus and the tube and ovary. So, uniformly inlet uterus, total hysterectomy and bilateral surgery are done. And this is the case. You see the intramural fibroid approaching and almost compressed towards the cavity. It is the compressed towards the cut section is beautiful, and the what is the cut section shows is the whole appearance. We'll have to show the whole appearance of the fibroid. And this specimen, the examiner asks you the what are the different type of complications, that is the degeneration, torsion, and hyaline degeneration, cystic degeneration, red degeneration, and more questions on the red degeneration. So you'll be prepared for that. Now, demonstration of the open myomectomy in the patient is the pre-operative kindly. If you want to take decision about the myomectomy with the young patient and with the nulliperas or one's child, you have been asked about the myomectomy. Myomectomy two types. One is the abdominal and maybe also vaginal. And vaginal, there may be also hysteroscopic myomectomy. And in case of abdominal, there may be laparoscopic myomectomy and also the open myomectomy. Now, open myomectomy becoming less and less, and abdominal, that is the laparoscopic myomectomy, has becoming popular. So, steps of the both of the cases, you will be asked this exam, and don't forget to give the vasopressor agent and to inform the anesthetist that I am giving the vasopressor agent. This is not uncommon, the cardiac has occurred. This is the simple question. Then the dissection, how will you dissect, and this is the myoma screw, and the dissection by finger dissection, and the scissor dissection, and the preoperative counseling before myomectomy. If by chance there is a opening of the endometrium, by chance there is a opening of the endometrium, if it is very small, you may ignore, but better to we can report by 30 feature. Now come to this is specimen, the cut section specimen. You also see the other part, the lateral part. So you see both 4 surfaces to diagnose it. And this is the multiple fibroid, all types of fibroid. And if you get, you'll have to definitely the question, what are the different types of classification? Serous, intramural, and submucous. This is the broad classification and the preoperative classification, and where you will do. And in fact, for myomectomy, it is done in case of stage 3. In case of the type 3, also can start with the 2 up to the rest of the types can be done. And this is also varieties. There is a submucous, intramural, and also this is the submucous type, more in the myomectomy, that is the two type, and this is the subserous, same specimen, and the multiple myomas or myomectomy. Now we come to the cervical fibroid. Cervical fibroid, you can see the types. Always, this is the describe the specimen. There is a specimen of the uterus, and there is a internal. This is the internal os, and there is in the posterior lip of the cervix, there is a large mass. Probably there it is a case of cervical. No, also if you the other side, you also see whether it is a total hysterectomy or bilateral total hysterectomy bilateral. Type may be the vaginal, supravaginal, and vaginal, and for it may be anterior, it may be posterior into central, anterior, posterior, lateral, and central. These are the different types. And this is, you see, this is the specimen, the good specimen, mainly the lower part of the cervix, lower part of the total hysterectomy and bilateral. But this is the dangerous operation because the ureter lies on two sides. better to do the myomectomy first, then hysterectomy or repair of the uterus. The diagnosis is the cervical attachment of the cervical fibroid, form, fixity, pelvic position, widen cervix in the leg. So all the students, you please remember how to diagnose the cervical fibroid. And AUV is not the problem in case of usually the problem until and unless there are other fibroids also. And the pelvic pressure is the most important. The heaviness of the pelvis, and that is the pelvic is the bladder and bowels. And the bladder, the retention is common. Maybe also the frequency, maybe also the constipation also. And USG confirms the diagnosis, particularly for it is needed from the ureteric position. And you may detect the hydronephrosis and hydroureter. Also IVP can be. So this is the diagnosis. This is the typical picture, the lantern on dome of St. Paul, that is the fibroid, cervical fibroid. This is the perioperative case of my cases. Usually this type of fibroid better not to do direct hysterectomy without myomectomy. You do the myomectomy first, then hysterectomy you do. Myomectomy, then hysterectomy you will do. Or if you want to do also the keep the uterus, you myomectomy and then in the repair. And a better practical method is to keep a dilator inside the cervical canal. Dilator for vaginally inside the cervical canal. So you can see the cervical canal and it will be helpful for repair of the cervix. And now this is about the broad ligament fibroid. If you know, there are the two types of the broad. To describe this specimen, it is a specimen of the uterus and both the tubes and ovary, and this is actually the cervix, and there is a mass in the area of the broad ligament, and the mass is attached with the uterus. So it seems that mass has arisen from the uterus. So it is the pseudo broad ligament fibroid. And true broad ligament fibroid, actually it arises from the round ligament or the structures of the broad ligament, any fibrous tissue or the. So this is the difference of the pseudo broad ligament fibroid and this is the specimen. It's a 2 ligament problem. This fibroid, it is actually the operated specimen, and it has been separated, and I have taken this picture with this specimen. Symptoms, signs will be the same also the fibroid, and sometimes difficult to diagnose whether it is uterine fibroid or even sometimes the ovarian tumor. All the investigation I have described in the first specimen that we will do. And after opening, what will you do? You will not be able to see the clamp here. So you give a post-FOGSI incision in between the fallopian tube and the round ligament and approach an enucleation till the lower end reaches. That will help you. The intracapsular enucleation is fast done. And two broad ligament fibroid and pseudomonotonic difference is that ureter in case of true ligament usually lies medial to it. But in case of pseudo broad ligament fibroid, here the ureter usually lies lateral to it, displaces the ureter laterally. That is arises from the ovary. So this is actually the true broad ligament fibroid. But the ureter position may be changed according to where from the fibroid arises. We are aware of that. And hysterectomy has been done, but you can easily enucleate I have described in the post-FOGSI incision, enucleate the broad ligament fibroid and then repair it. And this is the true broad ligament fibroid. You can see after enucleation, side by side, or you can repair if you want to retain the. So tips of the specimen is there. For the tips of the specimen, I think majority I am also reaching the time also in front of the time. And first you observe and examine the specimen in all views, and then you keep it and don't stir it or make it rotate it like that, and move and rotate as minimum as possible and very gently to see all the structure. Avoid handling and tilting and the specimen jar throughout your viva. Many students see always with the jar, specimen jar is moving. You learn. No, you have seen, and then you face the question. Try to find out the anatomical structures along with the pathology. That will the most important. Anatomical structures and anatomical pathology proper diagnosis. Wait for examiner's question and answer specific so to that specimen. And if he asks the other types of specimen in fibroid, so you can give, not as a whole of the disease until and unless examiner asks for. Don't jump into the uncommon and irrelevant answer which examination has not heard. So examiner will then ask that uncommon and irrelevant answer you have given, examiner will go into the depth and you will be the track. So thank you for your patience hearing and for the opening batsman of the specimen. Thank you, Dr. Hachipur, Dr. Ashish, Dr. Ashok, and Dr. Sheila Madam. Thank you for beautiful. You have from the very beginning your award, and also Dr. Bhaskar Pal and Pratik has left, but thank you all of you for giving me the scope.
Thank you.
Thank you.
Thank you, Arudha, for an excellent demonstration of all types of leiomyoma uteri with their complications, their diagnosis, and how to handle the specimen when they are facing at the exam. One tip for the examinees that always examine a specimen from all sides except below. Don't try to examine the specimen from below because in case the formalin spills, not only your exam is spoiled, all other examinations are spoiled. So I think that's a very good tip that Arudha has given. Arudha, thank you very much. And thank you for the excellent collection that you have of different types of fibroid uterus. And as an extension of this, you can have he has talked about hysteroscopic myomectomy. We can also, when you get more time, we can discuss about the laparoscopic myomectomy and other forms of myomectomy and the closure of the bed, etc., etc. But that is for a later session. So thank you very much, Arudha. And so if there is any question or comments in the chat box, I'll check. There is
Welcome, Dr. Archana.
Good morning, ma'am. Good evening.
Sir, Mazi sir, can you stop the sharing the screen, please?
Which?
Stop sharing.
Stop, sir. Okay.
Good afternoon, everyone. Sheila madam, Ashish sir.
Yes, ma'am.
Oh,
Dr. Archana.
Sir.
Hey.
So nice to see you all. Shall I start sharing my screen?
Ma'am, 1 minute. Sheila ma'am, you wanted to say something, or should we move into this last session?
No, we can move forward now for the quiz.
Yeah, thank you, Mazi sir. Yeah.
Thank you, Dr.
I'll
Thank you,
share the
Mazi sir.
screen.
Yes, ma'am. Dr. Archana Kumari and Dr. Amaya Chuk for the quiz.
Yes. Good afternoon, everyone.
So shall I am starting the quiz.
Yeah.
Is my screen visible?
Not yet.
No.
It's loading. It's loading.
It's coming. Yes, now it has come.
It is there now?
Hello, Archana ma'am.
Yeah.
Yeah, my voice is visible. Voice is audible, right? And I'm visible.
Yeah, Ame, you are visible.
Okay, great.
So for the participant, let me inform them that this is the game pin 4458593. You can log into www.kahoot.it and enter the game pin to enter into the game. So I can see one person coming up as Cup, and I would please request you all to join through at least initial of your name, because at the end it is very difficult to identify the winners.
I think the participant is referring to the World Cup final that's going to happen now.
And please, whoever is B, please put your initial at least. Shivangini did a great job because he has entered the whole name.
We will give them some time to join, right?
Yeah, yes, madam. Usually we give time to them. Maybe it is 2:16 p.m.
We are going to give prizes to the quiz winners.
Yes, ma'am.
Okay, as well as the people, those who presented. Okay, so quiz committee can also contribute. Okay?
Okay, ma'am.
So that we'll encourage more and more people to join.
Whoever has joined us, Cup, please change your name. Put your initials.
Okay, we have many teams now.
21 people have logged in. So I hope all the participants are aware of quizzing in Kahoot app. Here, not only the correct answer, but also the time in which you answer matters for your position. So if you know the answer, try to click it quickly. Who is SP? Please change your name. There is one person as I. P and I, please change your name. We will wait till 2:20 p.m. and with the permission of Seela ma'am, then we will start. And this is a open kind of game, so people can log in even in between. So today, myself, Dr. Archana Kumari, Chairperson Quiz Committee, along with Dr. Amir Chug, who is the West Zone Coordinator for Quiz Committee for the year 2026, will be conducting the quiz. And today's topic is recurrent pregnancy loss, on which there was case presentation also. Whoever has logged in as I, please put your initials or proper name. So 34 persons have logged in and it is already 2:20 p.m. Shall we start, Sheila ma'am?
Yeah, please start.
Okay. So this is the ICOG quiz on recurrent pregnancy loss. And here we go with the quiz. It is single select option. All the questions are MCQ, single select. So this is just, this is not a question actually. So we will go to the, just try to skip this. Here is your first question. What is the minimum number of pregnancy losses required to define recurrent pregnancy loss according to ASRM? Very simple one. Answers are pouring in rapidly. So we have given 20 seconds to answer. The correct answer is 2. Most of you have got it right. We move on to the second question. This is the scoreboard, Dr. Nishu at the top. Which immunological factor is most strongly associated with recurrent pregnancy loss? Is it elevated ANA, high CRP, increased NK cell activity, or low complement? So the correct answer is actually increased NK cell activity. Only 9 of you got it right. We move on to the next question. Scoreboard. Shivangini moving on to the top, followed by Dr. Nishu and Dr. Deepika. So a woman with recurrent pregnancy loss is found to have septate uterus on 3D ultrasound. What is the best treatment? Hysteroscopy, septal resection, progesterone therapy, abdominal metroplasty, or cervical sucklage? So the correct answer is hysteroscopy, septal resection. Almost all of you got it right. That is so amazing. We keep some of the very basic questions for your knowing the basic knowledge. So here's the next one. A couple with RPL is found to have balanced reciprocal translocation in one partner. So what is the best reproductive option? IVF with pre-implantation genetic testing, surrogacy, natural conception, or go with IVF with donor gamete? So the correct answer is IVF with pre-implantation genetic testing. Most of you got it right. This is again a very basic question. Next. Deepika is at the top of the scoreboard, followed by Shivangini, Nishu. What is the most common uterine anomaly causing recurrent pregnancy loss? Unicornuate uterus, septate uterus, arcuate uterus, or bicornuate uterus? So the correct answer is septate uterus. The scoreboard displays Deepika at the top, followed by Shivangini and Dr. Nishu. We move on to the sixth question. What is the most common overall cause of early miscarriage? Hormonal disorder, chromosomal abnormalities, infection, or antiphospholipid syndrome? Again, a very simple and basic question. So here is time's up, and the correct answer is chromosomal abnormalities. 40 out of 44 have got it right. That is amazing. Scoreboard, Deepika remaining at the top. Next question. A patient with RPL has TSH of 6 milli-international unit per liter and positive anti-TPO antibodies. So what is the best management? Would you start levothyroxine or just observe her? Start aspirin or start progesterone? So the correct answer is start levothyroxine. Deepika remaining at the top, followed by Dr. Nishu. Here is the next question. What is the investigation of choice for diagnosing uterine malformation in RPL? Is it MRI, hysterosalpingography, laparoscopy, or 3D ultrasound? So the correct answer is 3D ultrasound. 33 of you have got it right. The scoreboard, Deepika remaining at the top, followed by Harleen has taken a leap. Patient with 3 recurrent abortion and positive lupus anticoagulant anticardiolipin antibodies. The best management for next pregnancy is progesterone therapy, low molecular weight heparin plus aspirin, steroid alone, or sucklage. So the correct answer is low molecular weight heparin with aspirin. And this question was got right by everyone who has participated. That is amazing. So Deepika remaining at the top, Harleen maintaining the second position. 2 painless second trimester abortion with soft dilated cervix and no contraction. What is the likely diagnosis? Antiphospholipid syndrome, placenta previa, uterine septum, or cervical incompetence? Very easy clinical question. The answer is cervical incompetence. So all of you got it right. Deepika remaining at the top, followed by Harleen and Sivangani. Which inherited thrombophilia is the most commonly linked with RPL? Proteinase deficiency, antithrombin 3 deficiency, factor 5 Leiden mutation, or protein C deficiency? So the correct answer is factor 5 Leiden mutation. And this question was answered only by half of you. So Deepika remaining at the top of the scoreboard. Next question, a woman with RPL has heterozygous factor 5 Leiden mutation. What is the current recommended management? Low molecular weight heparin only if there is previous thrombosis, aspirin plus LMWH in all pregnancies, steroid, routine anticoagulation in pregnancy. So the correct answer is you have to give a low molecular weight heparin only if there was previous thrombosis, otherwise not needed. So let us see the scoreboard after this. Deepika remaining at the top, Harleen moving on to the second, and Dr. Nishu third. So next question, in which condition is progesterone supplementation useful? Chromosomal abnormality, septate uterus, APS, or luteal phase defect? Again, very easy one. I hope most of you will be able to answer, and that is my intimation was correct. 36 of you got it right. It is luteal phase defect where progesterone supplement is useful. And when we look at the scoreboard, Deepika maintaining the top position. Next question, patient with RPL is found to have anti-cardiolipin antibody positive once only. So what is the next best step? Do anti-beta 2 glycoprotein testing or repeat the test after 12 weeks, start aspirin therapy or start LMWH immediately? So the correct answer is repeat the test after 12 weeks because anticardiolipin usually persists for 12 weeks. So next, here's the scoreboard, almost remaining the same. This is the last question I would be taking, and then I would hand over to Amay. So in which situation is parental karyotyping indicated? Only after 5 miscarriage, or in all cases of RPL, after 2 biochemical pregnancy, or when the product of conception shows chromosomal abnormality? So the correct answer is only when the product of conception shows chromosomal abnormality. So we will move on to scoreboard. Deepika is at the top, followed by Nirosha and Sivangani. Dr. Ame, are you there?
Yes, I'm there.
So I think I took 15 questions. So from 16 to 30, you take over.
Yeah.
I will move the screen.
Ma'am, you can share the screen from there because
yeah. I'm sharing. This is the question.
Next question, which endocrine disorder is associated with RPL? Is it PCOS, hypothyroidism, diabetes, all of the above? You've already got 40 answers. It's a very simple question, to be honest. Yeah, most of you have got it right. All of the above, everything from the above is associated with RPL. Let us have the scorecard. Deepika is still leading, Nirosha at second, and Shivangi at third. The next question. What is the most important investigation in suspected antiphospholipid syndrome? The options are ANA, lupus anticoagulant and angiocardiolipin antibodies, anti-dsDNA, or D rheumatoid factor. 28 answers we've got, or we've got almost all the answers now, 45. And most of you have got it right. Almost all actually lupus anticoagulant and angiocardiolipin antibodies is the right answer. The scorecard shows, I think Deepika must be leading. It is her day today with Nirosha in second and Shivangi at third. The next question on the screen is a woman with recurrent abortions has a normal has normal investigations, what is the expected live birth rate with supportive care? The options are 35%, 50%, 20%, or 70 to 75%. This is a bit tricky, I believe. We've got almost 44 answers. And the correct, okay, 70 to 75%, 27 of you have got it right. It doesn't make a difference for Deepika though. Second position we have Harleen and third is CUP. The next question, and this is a double point question if I'm not wrong. What
No,
is
it is
the
just
to diagnose APS and recurrent pregnancy loss? The options are ANA, CRP, lupus anticoagulant, or anti-DS-DNA. Thirty-eight of you have got it right. The answer is lupus anticoagulant, the best test to diagnose APS, antiphospholipid syndrome, and recurrent pregnancy loss. The scorecard shows we still have Deepika who's leading at 17,000 points. Now Harleen jumps to second and Nirosha to third position. Next question. Woman 30-year-old with 3 early miscarriages less than 8 weeks. All the investigations are normal. Most relevant management in the next pregnancy is, the options are immunotherapy with intravenous immunoglobulin, low molecular weight heparin along with aspirin, progesterone supplementation or reassurance, and early pregnancy monitoring. All the investigations are normal. The correct answer is reassurance and early pregnancy monitoring. Only 14 of you have got it right. Let us see the scorecard. Any changes in the scorecard because of this question? Because less than half of you have got it right. It is the same scorecard. Deepika 1, Harleen 2, and Nirosha at number 3 position as of now. Next question. Which drug is most commonly associated, used with heparin and antiphospholipid syndrome associated pregnancy loss? Prednisolone, progesterone, estrogen, aspirin. Very simple. I think Kahoot will answer this for us. We've got almost all the answers. Oh, okay. 39 have...
Still 4 and 2, 6 persons were not able to answer.
Yeah. I think they got confused in the... Let us see the scorecard. I think it's going to be the same. Deepika, 20,000 points. Harleen, second number. And Nirosha at number 3 position. The next question. Which of the following lifestyle factors is associated with an increased risk of miscarriage? The options are high caffeine intake, smoking, obesity, or alcohol intake. Which of the following?
This is a multi-select, actually.
Yeah, it's a multi-select question. Increased risk. Okay, this is a different. We've got smoking, we've got alcohol, and we've got obesity. Apart from caffeine intake, I think all of the three have increased risk when it comes to.
But let's see the scoreboard because this is not reflecting us.
Exactly, yeah.
So there's a tremendous change in scoreboard now.
Oh,
Remaining the lead,
the
but
number 2 and number 3 are not seen now, Hiroshi. I think it is Shivi who's at number 2 and Dr. Nishu at number 3.
Yes. Next question.
Next question. Which infection is classically associated with recurrent pregnancy loss? Options are rubella, second listeria, third toxoplasmosis, or fourth chlamydia. Is classically associated with RPL. We've got 30 answers with us. 5 seconds to go. The correct answer is listeria. Only 6 of you have got it right. Oh, I think now there's going to be a change in the scorecard. Is it or is it not?
Deepika has not changed. Shivi is also there, second.
Shivi comes at second. Deepika still remains on the top. Congratulations to her till now. Nirosha at third
Move
position.
on to next question. Yeah.
Which chromosomal abnormality is most commonly detected in an abortus karyotype when it comes to RPL, Turner's, trisomy 21, trisomy 16, or triploidy? Most common. We've got 40 answers. 3 seconds to go. The correct answer is trisomy 16, and only 13 of you have got it right. Coming to the scorecard. Oh, still the fortress is taken by Deepika. Number 2, Nirosha, and number 3, Meenu. Next question. Which investigation best evaluates the uterine cavity and tubal patency simultaneously? Hysteroscopy, MRI, laparoscopy, HSG. Best evaluates the cavity as well as the patency simultaneously. We've got almost all the answers with us. The correct answer is HSG. 31 have got it right. Looking at the scorecard.
Change.
We've got a change. Nirosha jumps to number 1, Meenu at number 2, and Deepika comes to number 3. We've still got 5 questions, I believe. Let us see.
Yes. Next question.
Next question. Which maternal age group has the highest risk of recurrent pregnancy loss? It is less than 25, it is 25 to 30, 30 to 35, or more than 35 years. Highest risk. Of course, more than 35 years. And I think almost all of them have got it right.
Yes. Only 4, 5 are
Only
long.
5 have not got it. The scorecard. Nirosha at first, Meenu at second, and Deepika is at third. Okay, it's a very tough fight, to be honest. Very close, all the points are. Let us see the next question. Which uterine pathology can contribute to recurrent pregnancy loss? Submucous fibroid, endometrial polyp, intrauterine adhesions, all of the above. Which uterine pathology can contribute to recurrent pregnancy loss? We've got almost all the answers with us. Yes, it is all of the above. All the options were right. And I think the scorecard would remain the same. Nirosha at first, Meenu at second, and Deepika at third. The next question, last 2 questions to go. Which hormone is essential for the maintenance of early pregnancy? The options are luteinizing hormone, prolactin, estrogen, or progesterone. We've already got 30 answers with us. A very simple question. Which hormone is essential for the early pregnancy maintenance? Of course, it is progesterone. 43 of you have got it right. The scorecard shows Nirosha at number 1, Meenu at number 2, Deepika at number 3. So I think we are at the last question. Or
Yeah, we are at the last question.
last question.
Last, no, second last.
Second last. What is the ideal timing for cervical encerclage in a woman with a history of cervical incompetence? 8 to 10 weeks, 24 weeks, 18 to 20 weeks, 12 to 14 weeks. The ideal timing for cervical encerclage. Previous history of cervical incompetence, very important. Okay, 40 of you have got it right. Around the NT scan, 12 to 14 weeks is the right answer. If we look at the scorecard, I believe Nirosha at number 1, Deepika at number 2, and Meenu comes to number 3. So Deepika has gone to number 2 from number 3. Last question for the day. Which of the following does not increase the miscarriage risk? advanced maternal age, arcuate uterus, smoking, or balanced parenteral translocation. We've got 36 answers. The correct answer from the options is arcuate uterus. It does not increase the risk of miscarriage. The final scorecard, I believe ma'am should read out the names now.
The podium will be displayed.
Okay, we've Deepika at second, Meenu at third. And ma'am, please, if you can do the honors.
I think Nirosha is first.
Yes, Nirosha is first.
Nirosha
Yeah,
is first.
congratulations. Congratulations.
So Nirosha, Deepika, and Meenu.
Yes.
So
Actually, Deepika
can you
was...
just put your name and email ID and phone number in the chat box? So I will stop sharing now. I'll stop sharing the screen.
Well done, Archana. Very well conducted. Good.
Thank you, Amay, for
Yeah.
being there
Thank
with
you,
me.
Amay.
Thank you, ma'am. Thank you so much for giving me this opportunity. And a happy Women's Day to all.
May I know Dr. Amay is from where? I should
I'm
know.
from Pune, ma'am.
Okay.
Yes.
Thank you so much, Archana ma'am and Dr. Ameya. Sheila Mane ma'am, for your final comments, please.
Madam, you are muted.
Sheila Mane madam, you want to say anything final, or otherwise we will close the session, ma'am? Dr. Ashish sir.
Madam is actually muted, I think.
Sheila ma'am, you are muted. Would you like to have any comments? Madam is telling to unmute. Host team, please unmute Dr. Sheila Mane ma'am. I don't know where it's...
Yeah, madam is unmuted now.
Yes, ma'am. No, madam is still muted.
Why this is happening?
Ramnath,
who is the host team?
Ma'am has messaged to unmute me.
Yes,
Yeah,
sir. Yogita
Yes,
is there.
yes.
She is just unmuting.
Can
Yogita,
you
please
unmute Sheila ma'am? Sheila
Yes,
ma'am.
yes, ma'am.
Video is there, mute is there.
Ma'am, I already sent the request. Please accept.
Sheila ma'am,
Hello,
please unmute.
Sheila ma'am. Hello, Sheila ma'am.
Ashish sir. I think their video is on. There is some issues from your end. Can you unmute them then? Both of their video is on. They are not. They're muted actually.
Why this is happening actually?
Hello,
yeah, Dr.
Sheila
Sheila,
ma'am.
you can unmute from your end itself.
Yeah. Maybe sometimes this madam has joined from mobile. Sometimes it is not visible at the bottom. That mute and unmute button.
Ashish sir.
Ashish sir is also not there.
Actually, Sheila ma'am is I'm seeing from two devices, but still it's muted showing.
Let us wait for a few minutes.
Yeah, otherwise.
At this time, the participation was good. 45 people logged in. That was good number because there was a time when only in one quiz I found only 20 or something like that were logged in.
Yeah, the initial few I think was very less, but subsequently it's increased in this. Ramnath, could you sort out the issue?
Yeah, I'm just calling, ma'am.
Otherwise, we'll just stop. Hello.
I think there is some problem.
Okay.
Should I call Sheila, madam?
Okay, madam. Yeah, no, madam. Madam is in the call.
More and more so that we get more and more people. You are in a medical college. See to it that more college students join. Okay.
Okay, ma'am. Thank you.
Well done. Thank you, Dr. Ashish, for being there, and everybody. Thank you.
Thank you.
So I'd like to thank you. I'd like to sincerely express our thank you to our FOGSI president, Dr. Bhaskar Pal sir, and entire FOGSI team. The ICOG team led by Dr. Sheila Mane madam, Ashok Kumar sir, Dr. Sadhana Gupta, then Dr. Pratik Tambe, and my senior colleague, that is Ashish sir, for thank you so much for your constantly being there. We'd like to sincerely thank for our having the first session, that is shoulder dystocia, by Dr. Hemant Deshpande sir, for giving your valuable time as your expertise for having this session. We'd like to thank the students, that is for excellent presentations, Dr. Shivangini Mehta, Dr. Vartika Kumari, and their professor and head, Dr. Moyer Gandhi, for your guidance to the students, and all the faculties, Dr. Ashish Mukhopadhyay sir, Dr. Shailaja R. Bidri, Dr. Uma Pandey, Dr. Rujuta Phuke, and Dr. Gota Doke for an excellent show in the case. We had started for a case that is a specimen session from this, and I'd like to sincerely thank Professor Arup Kumar Maji sir for starting the session with a very important specimen on different types of fibroid and showing that. And finally, we have the constantly going for the second year in the quiz session, which is becoming exciting for the students, and they're now participating in a larger number. I'd like to sincerely thank quiz committee chairperson, Dr. Archana Kumari, and conducting for today's session, and Dr. Amey Chug. Thank you so much. And in the next month, in the month of April, we would like to have with the different topics, different medical college, and for the quiz as well as for other topic also. So thank you so much for all of your participation and giving your valuable time for ICOG. Thank you so much.
Thank you. Thank you.
Thank you,
coordinating also. It's a tough job to coordinate every month.
Yes, ma'am. Thank you so much. It's going 5 year plus, and it is because of the support of the FOGSI ICOG, and maybe from 2 years you are seeing from the last 1 year or so. So thank you so much. Ramnath, you can stop the record.
Thank you. Thank you, sir.
Bye, thank you.
Thank you so much.
Thank you. The end of this program.
Ashish sir, you come out finally, sir. Thank you so much. You want to say anything, Ashish?